So our first speaker for today's event needs no introduction. Sir has left an indelible mark in the field of medical science, the person whose enthusiasm, dedication, hard work has not gone unnoticed. Sir is currently a domain consultant learning and development in health professional education director RGUS Academic and Administrative Training Institute. Therefore, we look forward to Sir's rich presentation on the topic Introduction to Educational Methodology. Ladies and gentlemen, please welcome Dr. Munir and Masar with his huge round of applause.
At the outset, let me thank National Institute of Unani Medicine for the opportunity that is given to many of us, because this is not something which is very the core of any healthcare profession activity. This is more into the designing and implementation of the educational activity. And as a healthcare professional who is also training the healthcare professionals, it also is a requirement for the teachers to be aware of certain activities, certain policies, and certain concepts to be a better communicator and to provide a better training. So in this context, we have this session on educational methodology. The message says, learner is the focus of all educational activity. Agree? Or anybody who disagrees? I'll agree. If you agree, learner is the focus of all educational activities, there are two models of training that could be there. One is this model, then you have this model. To make and to ensure that learner is the focus, which model would be appropriate? First or second? Second, yeah, thank you. It is the second model which would be appropriate to make learner as the focus of all education activity. In fact, the trends in medical education, healthcare education, are now moving towards what is called as outcomes-based education or competency-based education. And when we talk of competency-based education, it is a learner who becomes the focus of all activities of academics. So in this context, understanding what are the tools and what is the procedure of making learner as the focus and ensuring the outcomes are established into the learner is important, and that is what this whole session is about. As any healthcare professional, including Unani professional, there are three roles that a postgraduate plays or a doctor plays. One is in the clinical area. As a clinician, your whole syllabus is almost like 90% focused on the clinical aspects of whichever specialty that you are into. The second area is research. And in fact, there is a separate paper on research methodology and statistics. So the understanding and learning of research is also formally introduced and inbuilt into your curriculum. The third domain is education or teaching, which is something which is very, very informal in our curriculum. Though we become teachers after post-graduation, there is hardly any training which is formally provided to be a teacher. Like when you become a teacher, you just go there and from your subject knowledge or domain expertise, you start communicating whatever you know or whatever you feel is important. Whereas teaching or education itself is a complete professional role. Therefore, to be a teacher, even the healthcare professionals need to have something of training, a formal training in educational methodology. And in the Rajiv Gandhi University of Health Sciences, for the past 20 years, we have been providing continuous training in education methodology to all the teachers, irrespective of whichever is the faculty. In fact, we have from the beginning almost like since 1998 or maybe 2000. Unani has also been part of the whole process to capacity build the teachers. So in this background, we need to have something of a formal training in education methodology, at least at the postgraduate level. And now because the outcomes-based educations are coming as a result of the Niti Aayog mandate, there could be some electives on education methodology. This whole session, the agenda of this session, maybe I'm told it's about 1.5 hours, is about six domains, 6 dimensions. One is understanding the skills for Unani professionals, which we already have discussed. There are 3 skills that the Unani professionals require. One is a clinical, the second is research, third is teaching. We already have discussed that. Second is to discuss education as a system, that we do a little later as the session progresses. Describe the adult learning principles, because all the students that you come across, whether it is UG or PG, are adults or adolescents. Therefore, understanding your audience, the way they learn and the way you can successfully teach them and train them is important. So, understanding adult learning principles and the tools for academic planning. How do you plan for your academics, whether it is designing a curriculum or designing a curriculum implementation or planning for a lesson or preparing a question paper or conducting a practical examination or a clinical examination or a theory-based examination. All these require certain tools of planning in each of these areas. What are those tools? Very briefly we will be discussing. Then classify the teaching learning activities. Once you have planned that this is the outcomes you require, what are the instruction activities which are appropriate? We will be discussing about that. And finally, what are the assessment tools? Broadly speaking, what are the assessment tools? We will have a discussion on that. So it is based on these six domains, and later there would be a kind of workshop, not workshop like you will have hands-on training on lesson planning that would follow later in the next session. To understand education as a system, you will be able to define education according to WHO. State what are the components of education. Illustrate a basic teaching model and discuss BIC's constructive alignment. See, much of this is drawn from the higher education domain and adapted for healthcare education. To define education, the WHO defines education as a continuous process. You can see here there are 2 words. Education is a process, it's not a product. Like having a BUMS or MD Unani or PhD doesn't only constitute as education. It is something which a person continues to learn, continues to acquire. Therefore, it is a process, and it is a continuous process because it doesn't stop anywhere. It is something which is continuous. So, education is a continuous process which has a chief goal. There is a purpose for education. Now, what is its purpose? When we discuss in a kind of informal discussions, there could be many definitions, many ideas that can crop up. But what is required is an idea or a concept which has a theoretical background and which has an applicability, a realistic applicability. Therefore, to understand what is the chief goal of education, the WHO has says the purpose of education is to bring about desirable changes in the behavior of learners and the relatively common basis. So when you say that education is happening, where is it happening? Naturally it has to happen in the learners. And how do you know that the learning is happening in the learner? It is by the change in their behavior. Let me give an example. How do we relate education or learning to the behavior in the learner? Take a very common example. You see that all of your teachers are maybe going to become teachers, you have some kind of a experience with the students. You tell the students that, see, the class starts at 10 o'clock in the morning. And you are there in the classroom at 10 o'clock or maybe before 10 o'clock. You tell the students at 10 o'clock you will start the class. And you have to be in time. There are students who keep coming beyond the time also. And you give a limit that, okay, see, this is the last day, from tomorrow or from next week I will not go. You have to make whatever you have to make so that you are in time. No, even after that ultimatum time, if the students keep coming late, what do you say? What do you say about them? Say, look at this fellow. I've kept on telling to come in time, and he is the same. He is the same or she is the same. When you say, it relates to their behavior. Behavior is the same, that they are coming late even after told that you have to come in time. In fact, you don't have to be told in time, you have to be in time. That's a different matter. But you relate learning to the change in the behavior. If somebody starts coming in time, you say, see, that person is coming in time, so the change in behavior. So this is what you see in the change in behavior. The change in behavior, which has to be relatively permanent, because whatever professional learning you are acquiring need to be established in you for a long period of time. So to summarize it here, education is a continuous process which aims to bring about certain desirable changes in the behavior of learners on a relatively permanent basis. Now, how does it happen? What are the sources of this change of behavior? This change of behavior can happen as a result of acquiring knowledge. When the students acquire knowledge, their behavior changes. To give an example, imagine yourself, or let me tell my example. When I got into this medical course, the first day, maybe first week, the teacher was talking in anatomy, superior, inferior. Superior, inferior. These were two words which stuck me. And I thought I am superior, because I got into this course. And my other friends who were there in my 10 plus 2, they could not get a good course, so they are inferior. That was my idea. Now, as I listened to this teacher in anatomy about superior, inferior and many other things, then I come to realize this superior or inferior doesn't mean anything related to getting into the course. It has some different meaning. No, my behavior towards that word, meaning, it changes. That this superior and inferior are different. Why did it change? Because I acquired a different meaning for that word superior and inferior. Because I acquired the knowledge, my behavior towards that word changed. So this is what is behavior change. And it happens as a result of acquiring knowledge. The second factor that can bring about the change is improving skills. Now imagine yourselves when you were in the first clinical posting, the way you were doing the palpation of liver or maybe palpation of the pulse or whatever other clinical activity that you were doing in the first clinical posting. And by the time you have graduated in your internship or in your post-graduation, the kind of activity that you are doing. Your behavior, the capacity and the confidence is totally different because you have acquired the skill of that performance. So this is behavior change which can happen as a result of acquiring a skill. And most importantly, developing the attitude. The way we develop attitude over a period of time defines how much professional we become. Imagine yourself, one more example. In your first clinical year, you are posted to some ward or in the OPD, and there is a patient with ulcer, a foul spinning ulcer, and the first year students or second year, whenever you post them, holding a kerchief and doing that work. Right? The same person, when you come to your final year, your kerchief is not there. Because your attitude towards the profession, towards the patient, and towards the patient care has changed. So, because of that, your behavior of holding the kerchief or not holding the kerchief, it changes. Now, you can see the factors which bring about the behavior change. You have acquiring knowledge, skills, and attitude. These bring about the behavioral change, and that behavioral change it constitutes as education. Now, this is the definition of education, and this definition will give you the complete idea about education, or at least it will direct you to where to find any kind of clarity that you require if you have to understand education. Now please remember these three last lines, or these three words: These are very important for our planning. These are some of the planning tools that we have. To go further, the whole of education is classified, or the curriculum is classified in 3 areas or 3 domains. One component of education is what is called as setting the direction. We have said the purpose of education. The purpose of education is to bring about desirable. So when you say what is the purpose of this session, what is the purpose of you training the students into a particular clinical skill? What is the purpose? What is that they are going to perform? Is what is called as the outcomes or learning objectives. And these learning objectives, these are the learning objectives or the purpose or the outcomes that you expect the students to perform. The second area is how do you bring about this learning outcomes. You say this is the outcome, the student will be able to perform this. How do you make the student to perform? Is providing some instructional activities, the teaching learning methods or teaching learning media. And once you have taught, the teaching is done and the students have learned, you believe the students have learned, then what is to be done is to check whether the students have really learned it or not. So this is called as the student assessment. These 3 constitute the 3 components of curriculum spiral, and these are interrelated. The way education objectives are written, these influence how the teaching has to be done, and these also influence how the assessment has to be done. Let me give an example. A very common example is to measure blood pressure. Any healthcare professional would do that. Now, if the purpose of education, a purpose of learning, is that the student will explain, or the student will state the normal range of blood pressure. What is the normal range of blood pressure? Giving a lecture would be sufficient for the student to learn what is the normal range of blood pressure. Now, if the student has to tie the cuff around the arm of the patient to measure the blood pressure, if I give a lecture explaining, see, this is how the instrument will be, this is how the cuff will be, this is how the wrap has to be done, and this is how it has to be. I may give a beautiful lecture, but at the end of it, does the student learn or not learn that? Now, how I make the student learn it? The better way would be to demonstrate it. To demonstrate how the cuff has to be tied around the arm. Now you can see the difference in the objective or the purpose or the outcome has changed the whole dimension of teaching. Whereas to understand certain thing, a lecture would be appropriate, but to perform something, a demonstration is needed. The same thing if you have to check whether the student is able to do or not. In assessment, if you want to check whether the student knows what is the normal range of blood pressure, you can ask a question in the theory or in Viva. And whatever answer the student gives, you can be sure the student knows it or doesn't know it. On the other hand, if you have a question in the theory or in Viva, how do you measure, how do you tie the cuff, how do you wrap the cuff around the arm of the patient, and the student explains it in Viva or explains it in a theory, how sure are you that the student can do it? You cannot be sure. The explanation is there, but performance you are not certain. Therefore, there, to check whether the student is able to do, you have to ask the student to demonstrate. This would be the appropriate assessment method. Now you can see there is a change, the difference in the assessment method based on the objectives. Therefore, understanding the objectives, stating the objectives is the most crucial element in any learning, in any curriculum implementation. More so in the competency-based curriculum, which is now coming, and maybe BUMS also will have to be. It is already done. BUMS first year, second year, competency is already done. But please check whether the objectives are clearly stated as performance objectives. And once the student attains this level, performs, the next level would be to go to the next level. You have completed this, now you go to the next level of objective, the same spiral continues. Next level of objectives, same spiral continues like this. It's not something which is a closed system. It is something which is evolving system. And this is called as curriculum spiral, or spiral of education, which has 3 components. Please remember this, and these are the 3 dimensions of any educational activity. The students have to be aware that this is what I am going to learn, and this is how I will be taught, and this is how I will be assessed. Only then the statement that the learner is the focus of all educational activities will carry any authenticity. Otherwise, it's only a slogan. Now, how do you implement? When you teach, you all have a kind of template. Everybody follows the template. Whether you are aware that you are following it or you are not aware, involuntarily doing it, everybody follows the same thing. So generally what happens, you have a purpose in mind. Whether it is stated or it is not stated, you have a purpose that at the end of this class, at the end of this session, at the end of this course, the student will be able to perform this or this. So that is what is your objective, what you expect the student to perform. The next thing is, sometimes involuntarily we feel we have to do the teaching. Now we have the objective, we have the purpose, and then we go into the teaching. But let's take a pause here. Does it always happen like that? That you say this is the outcome, and this is the expected outcome, and you go on bombarding with the lecture. What do you do when you are taking a class? Yesterday you have started the class. Today you are continuing that. Before you start your lecture, you generally start, or there is something else that you do?
You summarize the previous class.
You summarize the previous class. Or you want to revise it. Or you might ask some questions about that previous topic to the students to check whether they already have some kind of an idea, so that you can build on that. That is called as entry behavior assessment. Before starting the teaching, you have stated this is the outcome you expect, and before you start teaching, you check whether the student knows the previous required thing which you can build upon. So this is called as entry behavior assessment. Entry is beginning. Behavior, please relate it to the definition of education. Behavior is the knowledge, skill, attitude. All these constitute the behavior. And assessment is you are checking what the student knows in their knowledge, in their skill, in their attitude. So once you do the entry behavior assessment, next thing is to start the lecture, and after the teaching, whatever lecture or whatever demonstration, after that you have the assessment. Now this is a kind of formula also. This is the basic teaching model given by Glaser, and this also is a formula. Like for example, you have come across some topics where the students are not able to perform well. There are some subjects where the students perform well, and there could be some batches which do not perform well. You see that by the end of the assessment, there is some problem with the results. Some results are not good, some knowledge results are not good. Now how can you bring about an improvement in the results? How can you bring about a change? The formula is here. Once you get the result, this result gives a feedback to tell whether the teaching was appropriate or not. One problem, if the results are not good, if there is a problem with the results, one problem could be in the teaching. We might not have taken the right teaching method for it, or the teaching might not have been successful or effective. One issue. The second problem could be that the entry behavior of the student was not assessed. The students were either not prepared, or they were not aware of what they were learning, and whatever they have been taught, it has gone off tangent, it has not gone into their understanding. The second problem could be in the entry behavior assessment. The third issue could be with the objective itself. It could be that the objective was not stated, it was not written, the students did not know how they will be assessed. Or it could be that the objective was not communicated properly. Or it could be that the objective was not at the level of the learners. Perhaps something is at the level of PG and we have brought it down to the level of UG. In somebody's enthusiasm, we feel that this should be learned, everything should be learned. So it has been brought into the UG level, which is not the maturity level of the UG student. That could be one of the reasons. And the fourth reason could be the assessment method itself. The method we have used to assess the student, it might itself be a flawed one. So these are the four possible reasons which you can draw from this basic teaching model on how to improve education. Now when we are implementing education at the policy level, at the implementation level, at all levels, there are three factors which we already discussed. the outcomes, the instruction and assessment. And these have to be aligned. This is called as constructive alignment. Alignment which is constructive. This Professor Biggs, he has proposed to design the curriculum, the implementation of curriculum in the form of lesson plan, and whatever academic activities with these three elements into the single document. And this is what we call curriculum blueprint. When you build a house, when you build anything, you have a blueprint. You ask the architect to give a blueprint, and the architect gives a blueprint. And the blueprint is dependent on what is the purpose of that building. If suppose you want to have a house, the house will have a different structure. If you want to have a school, the school will have a different structure. If you want to have a hospital, that will have a different structure. Now if you build a hospital and convert it into a school, or if you build a house and convert it into a college, there is going to be a lot of problems. Therefore, the blueprint is what decides what is going to be the purpose. And in the curriculum also, there is a blueprint, there is a kind of template which says what is the objective or what is the outcome, what is the learning, how the learning happens, and finally how the assessment happens. So all these three things are fused together, which is called as constructive alignment, and this is something which is the foundation of the education activity. You have what are the expected outcomes, then you have the learning activities, and finally the assessment activities, whether these are realized. And when these three things are together in any document, in the curriculum document, in the lesson planning document, in the implementation document, only then there will be a clarity for the teacher, for the student, for the examiner, and for everybody. So these are the four areas that we have to understand about education as a system. Now by the end of this short session, if you are able to define education, if you are able to state the components of education, illustrate a basic teaching model, and discuss Biggs constructive alignment, if you can recall these four dimensions, I think is a successful one. Next, coming to the theories of learning. See, the theories of learning, the anatomy, physiology of medical practice. Because the anatomy or physiology or biochemistry give the foundation to understand what is going wrong, because you know what is not wrong. So what is going wrong and what could be the abnormality there. Therefore, understanding the theories of learning is something which is essential. And by the end of this session, you should be able to explain the psychology of learning, discuss the learning styles as per the walk style, differentiate between andragogy and pedagogy, and state the principles of adult learning as per Malcolm Knowles. These are the four objectives I have for this session. We'll come back and revisit these four objectives by the end of this session. Now, if you look at these four statements, beyond the four that we had earlier, you can see that there are two common things in all the statements. One is, each of the statement tells what you as participants will be able to do. The outcome is the participants what you will be able to do. It doesn't tell what I will do. Whatever I do is secondary. It is subsidiary. What you will be able to do is primary, and that is what is important. And second thing you can see in this is, each of this first word grammatically is a verb, and it explains some activity or some action. So that when the performance is being done, when the outcome is being assessed, you can check whether it is being done or not. On the other hand, instead of this explain, if I had written know the psychology of learning, or if I had written understand the learning styles, or appreciate the difference between andragogy and pedagogy. Now this know, understand, appreciate, these are also verbs. But these are not action verbs. These are passive verbs. Therefore, any writing of the objectives has to be as per the kind of protocol we have here. You need to have an active verb which explains what is the action, what is the activity the student will be able to perform. So this is something which is learning now. Now going further, The psychology of learning we can classify into three major areas. One is called behaviorism. We all have read about Pavlov's experiment, how the behavior happened, how the behavior change happened. Now what happens in behaviorism is, what behaviorism says is, there is a stimulus response equation. Whenever there is a stimulus, there is going to be a response. And you can predict. When they say, okay, now, when I flip this key, the slide changes or the animation changes. If the thing is working now. So this is stimulus, this is a stimulus, and that is a response, and it is predictable. I can predict. If I say that if I do this, or if I provide this, the student will be doing this. If I don't do this, the student will not be able to do this. A kind of behavior change that you see. So this is called behaviorism, the very basic level in the learning of anything. So behavior change. The second thing is, how does this behavior change? What makes this behavior change? This is called cognitivism. Cognitivism is knowledge. Now what happens in that between the stimulus and response? What is happening in the mind of the person? What is happening in the brain of the person? How this person is reacting? What are the factors that decide how the person will react? Like what is memory? The person has to remember certain things. What is memory? What is short-term memory? What is long-term memory? What is the load of memory? All these things constitute what is cognitivism. How does learning happen? As a cognitive activity, as a knowledge activity. So this is called as cognitivism. And the third dimension is called as constructivism. So constructivism is something which is interesting. What it says is, as all adult learners, as mature learners, we all have some experience. Take your own example. When I am talking something like this, when they say, when you start, before you start a class, what do you do? There were different responses. Somebody said you will summarize, somebody said you will review, somebody said you will ask some questions. So each person has their own way of responding to them. And that is coming from your unique experience. And this is what is called constructivism. Our responses, our learning happens by ourselves. We construct our responses. How does it happen? So this also has a stimulus-response equation. Like behaviorism has a stimulus-response equation. Constructivism also has stimulus-response equation, but the difference is, in behaviorism, the stimulus response is predictable. In constructivism, it is not predictable. Because each person has their own unique experience, and when you listen to somebody giving you some kind of an idea, you don't take that idea on the face value. You take the idea, you relate it to whatever you know, and then that product of your background understanding and what the idea has come, that is the outcome of your response, which is not predictable for everybody, because everybody has their own experience. Therefore, this is called constructivism. And all adult learning is constructivist in nature. Now, if you tell your students, see, you have an assignment to do. This is the assignment, you have to complete this assignment. As you observe, you will see some students will go to the library, some students will go to the one, some students will go to the community, some students will discuss with their seniors. There are different ways that they will be learning that, and that is their constructivism. Outcome is same, but the way they do that activity is what is constructivist. Therefore, this is my opinion. Each person should be given the independence to learn the way they learn, and that should not be forced on them. If you force something, that is not the way they learn, so the learning will not happen. It is something controversial now. If you agree, you agree. If you don't want to agree, you don't agree. Again, my opinion. We all have some kind of a complaint that students go to the library and read the books. Right. Now the current generation is not wired to read the books. They see on their iPad, they see on their mobile, they see on their laptop or whatever, and they learn from there. Now what is important is that they learn. It is not medium which is important here. Whether they read the book, some may read the book, some may not read the book, some may read something else. But ultimately, if you force them, the whole generation is digital native, they are called. digital native. So they are digitally wired. You do not disturb their nature of learning. Again, my opinion, it's up to you. You agree or not? So this is what is constructivism. Constructivism is each adult individual has their own way of responding, and it is not predictable because each person is unique for the response. Now the learning style, there are about 100 learning styles theories, and that I have taken only one. It is called WARK theory, W-A-R-K. What it says is, there are some people who learn by seeing something. They learn better when they see something. Like for example, if I have to learn something, if I see a video, if I see an image, if I see a picture, if I see something happening, it is easier for me to learn. These are called visual learners. There are some learners who are called auditory learners. Now, the auditory learners are those who learn better when they hear things. That seeing could be something which is a distraction for them. So if you see somebody in a class closing their eyes, don't feel bad. They could be auditory learners. Right. So, auditory learners. The third category is called as read, write, type. Read, write, type is the ones who you see in your class. They are going on scribbling everything. From the beginning till the end, they are writing. These are the people who learn that way. That is their style of learning. So, about 90% of the learners are audiovisual, read, write, type. Now, what is remaining is something called as kinesthetic learners. Kinesthetic learners are those who learn when they do certain things. They will not learn better when they see or they hear or they write. When they do certain things, when they are involved in that activity, that is when they learn. You might have seen some students in your class who look very dull, who do not respond, who do not answer anything, and look very disturbed in the class. You think this has some problem with this person, he is a slow learner. Slow learner. Now the same person, if you take that person to a laboratory or to a clinic, the kind of work they do would amaze you. These are the people who are kinesthetic learners, who learn by doing. Now the reason why you have to know this is, see 90% you can manage with your lectures, with your clinical demonstrations. But there still are about 7% of the learners who will not learn in these methods. They learn when they do. Therefore, your purpose is that everybody learns. Everybody gets that mastery. It is not how they learn. How they learn is according to their individuality, according to their style. So if you realize that there are students who learn in a different manner, you will provide that facility to learn without feeling offended. See, what happens is teachers sometimes are very sensitive. If I give a lecture and after that I ask questions, people don't answer, I feel, what? So nicely I have taught and you are not able to answer. So, this feeling of sensitivity or getting offended will not be there if you know that, okay, this person will not learn like this. He will learn like this. Let me give that thing. And after that he will demonstrate that he has learned or she has learned. So this is the reason why these theories are important for us to understand, because it opens up our horizons of understanding and we don't have any kind of a bias about anybody. So this is a style of learning. Now going further, all our learners are called adult learners. There is something called as pedagogy. You might have heard, because pedagogy is more popular. Popular because for the school children, the teachers who teach, it is compulsory to have education degree, education qualification. It could be something like D.Ed, it could be B.Ed, which is now compulsory. Without that, they cannot become teachers. So that is become popular because of the school teachers' pedagogy. Teaching the children, you can say pedagogy. Children. And you can see here, the arrows are one-sided. The teacher is there, and the teacher is giving the lecture or whatever, and the students have to learn. So this is what is pedagogy. But when you come to the adult learners will not fall into this bracket. You cannot be giving them one-sided view and tell, okay, you learn. Unless they involve into the learning, their learning will not happen. So this is called as andragogy. Andragogy is adult learning, and as you can see here, the teacher is here and the students are there, You can see the arrows are pointing both the sides, including the teacher is learning from the students, students are learning from each other, they are learning from the teacher. This is the model of andragogy, because andragogy is where you share experience and learning happens in a social context. So this is not social cognitive learning. And to provide the social cognitive learning, the learning happens in groups, it doesn't happen in isolation. And this concept was proposed by two people, one in 1930s and the other in 1960s. You can see here Lindman, 1930s, and Malcolm Knowles in 1960s. They wrote these books and explained how adults learn. What they said is, adults learn when they need to know. If I need to know something, only then I will learn. The meaning is, they have got into a profession. And what are the professional outcomes? Like you have the program objectives. If the program objectives state, this is the outcome of BUMS course. And the students realize that to perform the program objective, I need to know this. Then there is a kind of realization, I need to know this. So when they feel that it is essential, it is relevant, then they will learn. And they have a self-concept. I already told what is the self-concept of learning. It could be the audio learning, visual learners, kinesthetic learners. So they have their concept, this is how I learn. And that is individual for them. And adults base their learning on the previous experience. And that is what we explore in the entry behavior assessment, to check what the students already know, so that we can build on that. The fourth is, students learn when they are ready to learn. And when are the students ready to learn? When are they ready to learn? When the exams are announced. Right? That is when naturally everybody becomes alert to learning. Therefore, in the competence-based curriculum, there is something called as continuous assessment. So continuous assessment keeps the students on the track for learning. So this readiness to learn is continuous because of the continuous assessment. Next is orientation to learn. Now, the orientation to learn is around an issue or a problem. It is not about a single content. When a patient comes to any doctor, the patient comes with a problem. The patient doesn't come with anatomy, physiology, biochemistry, saying this is my anatomy, this is my physiology. They say this is my problem. So the learning has to be around that problem. And whatever biochemistry you want to remember would be because you have related with some case which has come and you try to understand what is the biochemistry behind this. Otherwise nobody understands biochemistry. Right? So this is about orientation to learn. Orientation to learn is holistic. It is not into compartments. And finally, you have a motivation to learn, which is intrinsic motivation. Intrinsic is that I want to learn. Extrinsic is I have to pass the exam. I have to pass the exam, I will pass the exam, after that everything is forgotten. Intrinsic is when I know this is my professional role and these are the skills I need to acquire, these are the competencies I need to acquire, it becomes my intrinsic motivation to learn. That there is an internal urge. So these are the adult learning principles. Now if you are able to explain what is the psychology of learning, discuss learning styles as per the WALK model, differentiate between andragogy and pedagogy, and the principles of adult learning as per Knowles. Now you can see the statements which are there at the beginning have become the questions at the end. What we stated, you will be able to do. Now we'll ask, are you able to do? So the outcomes or the objectives become questions. Therefore, writing the objectives properly is very, very essential for the success of any program. Now, is there any other program which has to intervene? Continue. 11, 20 minutes. Okay. Now, coming to the planning activity. We have discussed about the theories. Now, let us get into the planning. How to do the planning? In that, there are two things we have to understand. The planning of the outcomes. When we say, this is what the students have to be performing, we plan it at two levels. One is what is the domain what is the area, and what is the level in that area. Two things. What is the domain is what we call Brooks taxonomy, and what is the level within that we call Gilbert's levels. These two things we'll be discussing in brief now. By the end of this session, you should be able to classify learning as per Bloom's domains, explore the role of taxonomy in simplifying learning, and identify the predominant domain in the list of objectives. These are the objectives which I say you should be able to do. By the end, we will say, are you able to do? Now, this is a library, and you have gone to this library first time, and you are searching for a book. How easy it is to search for the book? Difficult. Not easy. Okay. Now, becomes easy. Why did it become easy? It is organized, structured, the names are visible, all these things everybody will see. But how did all this happen? For what reason it became organized, visible, structured?
For easy approach.
No, why it happened? For easy was okay. What made it happen like that?
Because it is the experience of it is not easy to find out in a certain way. So because of the certain experience that we have to do this, so it is accessible.
Okay, that is a trigger. After the trigger, what happened?
We
Okay,
have
let me.
arranged that.
Right.
We have done the work, we have arranged it.
Yeah. Why did you arrange like that? On what basis?
Easily,
For time management,
easy accessibility.
Fine. See, one thing is, we need to have a focus. When we think, this is where your mind training becomes necessary. Now, why it happened is, okay, there is a trigger. Because you felt that this is not easy, so you wanted to find some better way of organizing. So that was a trigger. And the trigger must have brought about some activity which made this happen. That activity is called planning. It happened because you planned. If you had not planned, it would not happen. Right? So the planning is the activity. And planning is very important. There is a saying, listen very carefully. Listen very carefully. Only 3 words are there. If you fail to plan, if you fail to plan, you plan to. Right. Now this planning is something which is very simple. To say what is planning? Is deciding before doing. If you decide before you do something, that is called planning. Simple. Technically there are many definitions. But vernacular, this is what is the definition, understanding. If you decide 1 minute before, if you decide 1 second before, if you decide 1 year before, whenever, before you jump, you decide, okay, now I am going to jump here. So I have an idea, I am going to fall. I am going to break my bones. All these things I have an idea. That is planning. Without knowing I jump. That is unplanned. If I decide I am going to do that, that is what is plan. Deciding before doing. Very simple. Now, how do you decide before doing? There have to be some planning. And these planning tools, there are some tools for designing the whole activity learning. And one of the tools is called Bloom's taxonomy of education objectives. This is very popular in the education field. And all the training, everything is based on classifying the learning into 3 areas. Please recall the last 3 lines in the definition of education. We said knowledge, skill, attitude. The same thing has become into the domains of learning. It is called cognitive domain. Knowledge can be, the learning can be classified into knowledge. Like when the student is explaining what is the normal range of blood pressure, that is knowledge. The other area is knowledge itself is not sufficient. You need to apply that knowledge, which is called as skill. And technically it is called psychomotor domain. Psychomotor domain. So when you have to hold something, when you have to write something, when you have to do something, some activity with the hands and fingers, that becomes psychomotor domain, the activity. So this is called the second domain. Third domain is what is the values, what is the communication, is what is the honesty, ethics, All these things together constitute affective domain. It is not affective, not affection, not effective, affective, starting with A, affective domain. So the three domains of Bloom are cognitive, psychomotor and affective. If you relate to the definition of education, knowledge, skill and attitude. So these are the three areas in which any learning happens. We take a very simple example of history taking. If the student is taking the history of a patient, the student must have the knowledge of what question I have to ask. So that is the knowledge. The student must know how to do the physical examination there, which is the skill area. And the student must know how to behave with the patient, how to communicate, how to show empathy, and how not to be humiliating in front of the patient. So these are the kind of behavior things, and these are called as affective domain. In any clinical activity, in any academic activity, these will be there. Some it may not be there. For example, if you have anatomy, what affective domain you will have? Except when you are doing dissection, not to show some kind of a respect for the dissection body. That could be the affective thing. Otherwise, it is skill and knowledge. Whereas in the clinical, all the three are important. Now, to give some example, the competency, if it is provide appropriate care to the newborn and neonate, if this is the competency the student has to have, it will have multiple objectives. For example, list the causes of neonatal distress. This is coming from the knowledge. This is the cognitive. When the student has to list, the student has to think or to decide. So this is knowledge, cognitive domain. And then the student may assist in the resuscitation of newborn. To assist in the resuscitation of newborn, it's not just the knowledge. Knowledge is required, not just the knowledge, but also requirement of the skill, performance. What are the performance it has to be done? And the affective domain is collaborate with the other members of the healthcare team. You alone, or the student alone cannot do everything. There has to be the interaction with the other people. How do you communicate to them? How do you interact with them? So these also, the team building is part of the same activity, providing the appropriate care. So this is what is called as affective domain. Now you can see here, the activity is same, but it has different dimensions. It has a knowledge dimension, it has a skill dimension, and it has an affective dimension of communication. So this way, the three domains come together for any activity. Let us have a small kind of, okay. Now what happens with this is, the knowledge, from basic knowledge, it has to improve to decision making level. In the knowledge area, the learning shifts from the basic knowledge to decision making. In the skills, it shifts from basic, you can see here, knowledge is there and skill is there. Because the skill cannot come without the knowledge. So basic knowledge skills are there, and this gets into a kind of sophisticated knowledge and skills performance. And in the affective domain, where a person may have some kind of a bias, some kind of a hold back. So beyond that unprofessional thing, the student will become more team building, communicative, lack of bias. All these things will have to develop as a professional. So this is how the shift of learning happens in all the three domains. We have a small interaction now. There are some statements. We'll have to identify which domain it belongs to. If the statement is mentioned the different risk status of pregnancy, is it cognitive, affective or psychomotor? Knowledge, skill or attitude? Cognitive. Okay. If it is position the patient appropriately for surgery, skill, it is psychomotor domain. If it is handle the child gently during examination, affective domain. Skill is there, but because this word gently is there, it becomes affective domain. Explain the medical genetics related to obstetrics gynecology. It is knowledge, cognitive. Conduct a normal delivery, psychomotor. List the environment factors affecting health, cognitive, and explain the ultrasound findings. Because it is again explained, it will be cognitive. So like this, you need to have a kind of recognizing which domain it belongs to. If you look at the curriculum document that you have in the competency base, these are listed, but I do not know how effectively these are listed with the verb. If at all, you need to redo it in your universities or in your institutions. Okay, what is the importance of these objectives? The importance of objectives are that when we state the learning objectives and outcomes, these are student directed. These tell what the student will be able to do. It doesn't tell what the teacher does. Because you said learner is the focus of all education activities. To make learner as the focus, you have to set the direction, and setting the direction is with the objectives. Then these shift the emphasis from what to how. It's not just what the student will do. It is also the quality of that performance. So when you state this is what is activity, the quality of that performance also gets inbuilt in that. And the next thing is interesting. What you see here is a railway track. It is not complete. We will complete. What happened here? The person here and the person here, they are not having communication. And this is what happens in our examinations. When the student goes to the exam and the question paper comes, he is like this. Because the teacher has taught like this, and the examiner thinks this is important. And that way the question paper comes here. And when it goes for valuation, again that person is a teacher. And you can see this is what happens. Therefore, what the objectives do is they bring about clarity of communication. Because the objective is there, it is listed. What is the student expected to do? The student knows, the teacher knows. And the person who is setting the question paper also knows. And the person who is doing the valuation also knows. So everybody knows this is what is expected. Therefore, it improves communication. Therefore, you need to have this planning tool properly with you. By the end of this session, if you are able to classify learning as cognitive, affective, psychomotor, explain the role of taxonomy in simplifying from basic to the higher cognitive, and identifying, you already have done the identification. So with this is one level of the planning tool. The second level of planning tool, before we break for tea, is about Gilbert's hierarchy. Now you have cognitive, psychomotor, affective, but not all the statements are at the equal level, or same level, uniform level. Some are lower level, some are higher level. Say for example, if you have to recall what is the normal range of blood pressure, that is one level. If you have to decide what is the treatment plan to be given, that is at a different level. So these are not same, not uniform. There is a difference in that. So this difference is to understand what is the planning that you need to do further. So by the end of the session, you should be able to discuss the hierarchy of learning according to Gilbert, then identify the levels in Gilbert hierarchy, and finally identify the role of Gilbert's hierarchy for learning. So these are the objectives we have for this session. And if you search on Google Bloom's taxonomy, you will not find this. When you search for Bloom's taxonomy or education objectives, you will see Bloom and then cognitive, affective, psychomotor. And within cognitive, you will find 6 levels: recall, understanding, application, then analysis, synthesis, create. So that creates a lot of confusion for many of us. Then for affective domain, they have about 5 levels. For psychomotor domain, they have about 7 levels. And all these become kind of complicated. The reason is, whenever these people have done the classification of psychomotor and affective, even cognitive, they have done from their native language. All these people are native English speakers, and they understand that language better. If we have to apply that, it becomes difficult for us. It's difficult to differentiate between what is value creation and value application, something like that. They look same for us. Therefore, WHO took a decision in the 1990s to simplify the levels. So Gilbert has brought about a simplified version, which is what we are going to discuss. So don't search for Bloom's levels, search for Bloom's taxonomy, the cognitive, affective, psychomotor. These are the basic levels. Within the cognitive, psychomotor, affective, there are different levels. And these different levels is what we see in Bloom's, in Gilbert's hierarchy. So Gilbert hierarchy, we take the cognitive, psychomotor and affective, and within that we have the different levels of entry level in cognitive, psychomotor, affective are the three, intermediate level and higher level. So all the three levels are there in each of these three. Therefore, you will have 9 different types of learning objectives, 9 different possibilities. In the cognitive domain, it starts with the entry level, which is remember. Student is able to remember, recall the definition, the values, all those things. The second level is called as understand or interpret. The understand or interpret is when you have multiple remember data. Let me give an example. The student has measured the blood pressure of a person. Now you ask the student, is it normotensive, hypertensive, hypotensive? How does the student tell this is normal or not normal? He cannot recall. Let's say first year physiology student. What the student will do is, the student remembers what is the normal range of blood pressure. Now the student remembers what is the value in this person. What the student now does is to interpret the current value with the normal range. Relating the current value with the normal range, the student says it is normal or abnormal, which is an understanding or interpretation. It is not the same level as remember. And when the student says it is now abnormal, what is it has to be done is what is the next level of problem solving. So these are the 3 levels in cognitive domain. To recall, to remember, to understand or make interpretation based on what they remember, and then taking a decision on the basis of understanding. You cannot take a decision on the basis of knowing something, remembering something. That will be disastrous. You need to take a decision only on the basis of understanding. So this is the way the traction of learning goes. Similarly, in the psychomotor domain, to learn any skill, the first thing that the student does is to observe and imitate. Any skill the student has to learn, the student observes from the teacher and imitates it in front of the teacher. And then second thing is the student performs it under the control of a teacher. The teacher is observing, under supervision, the student does it. If anything goes wrong, the teacher says, no, this is going wrong, you improve. This is going wrong, improve. And the teacher says, this is going right, you continue. So this is what is control. So once a teacher is confident that the student has gained control over it, it becomes automatism, where the student can independently. Now the third level, the third domain is affective domain. In that communication, ethics, all these values, all these things come. So how does a person learn how to communicate? By counseling, how to be gentle with the patient. So the first level is called receiving. The student has to keep the mind open to receive. Yes, this is how it has to be. That you agree, okay, now I have to be gentle with the patient. Receive it. If you say, okay, what is that? I am taking the case. The patient is talking, I am talking. Why I should be gentle? Anyway, they will talk. So this also could be an attitude. The attitude is if you have open to say, okay, I have to be gentle. I have to be related to this. The next level comes is response. What is the response? How do I become gentle? This again the teacher demonstrates how to be gentle by the role modeling. And finally, when the student has the cycle of receiving and responding continues, it becomes internalized. That is what is independently internalized. So these are the 3 levels in which the learning happens. Right. Now, this becomes easier for us also because there is not much of a language problem to differentiate between what is responding, what is receiving, what is internalization. Right. So it becomes, and what we have to do is whatever you have, your objectives which are in your competency document, you have to classify them into cognitive, affective, psychomotor. Within that, you also have to classify them as entry level, intermediate level, or higher level. Once you do that, it becomes easier for you to apply which is appropriate teaching method and which is appropriate assessment method. So what this Gilbert does is, it improves the learning of the writing of the objectives at the progressive level, from entry to intermediate to higher. It also is useful to assess the entry behavior. Suppose you are training something for the understanding or the decision making level. Now you will check whether the student is able to recall. If the student is not able to recall, teaching them about the understanding or interpretation level will be of no use. So it helps in the entry behavior also. Then for the what is the appropriate teaching method? For this level, what is the method? For this, what is the method? There are methods which are appropriate for each level. And of course, for the assessment, which is the relevant assessment tool. Now you have one more activity. You have to not only say which is the domain, but also say what is the level. Is it level 1, 2 or 3? If it is list the causes of anemia during pregnancy, cognitive, and it could be entry level, C1. C, cognitive, first level. Insert property under the supervision of teacher, psychomotor. And because it is under the supervision of teacher, it will be under control, P2. Clarify the doubts of patients regarding lifestyle management, communication, affective domain, and because it is a response. The patient has asked something and the student is responding, it will be A2. Formulate plans to initiate appropriate screening measure. When you are making a plan, it will be basing on your understanding, interpretation and understanding. So this will be at the cognitive 3 level of the highest level. Conduct screening for high risk pregnancy independently. Conducting something, performing something will be psychomotor, and because it is independently, 3rd level. Listen to the patient with empathy during history taking. Listening. Yeah, exactly, yes. And the last one, recognize emergencies in units. Recognize, this could be the emergency. So this will be C2. Because to recognize, the student has to understand. It is not something which is recall. Right. So these are some of the objectives. I have tried to classify them into the domain and the levels. So with this, if you are able to discuss the hierarchy of learning according to Gilbert, identify the level of objectives, which is what we have done, and explain the role of Gilbert's hierarchy for learning, for the traction of learning from the simple to the higher, for the appropriate teaching learning method and to the appropriate assessment tool. With this now we'll take a break and we'll go further in.
And myself, the person whose enthusiasm and expertise in his field has earned him remarkable success. We are thrilled to have among us a highly respected and esteemed lady, Professor Shamim Ma'am, at the Department of Ilmul Qabalat from Amraze Niswan, the trailblazer, patriot and pioneer personality, and of course the one who forms the backbone of our department. I feel honored to call upon his state Professor Arshia Sultana Ma'am, who is a living inspiration to the young ones, whose pioneering spirit and willingness is unmatched. Now, lastly, I would like to call someone whose punctuality, dedication and hard work is unmatched. Professor Bazia Begum Ma'am, please come on stage.
بسم الله الرحمن الرحيم والتين والزيتون والتين والزيتون وطور سينين وحامل بين اليمين لقد خلقنا الإنسان في أحسن تقويم ثم رددناه أسفل سافلين إلا الذين آمنوا وعملوا الصالحات فلهم أجر غير وما يكذبك بعد بالدين أليس الله بأحسن الحاكمين.
Thank you, sir. Now I will request Director Sir to present the token of justice to Munir and Niswan. Please clap. Now I request Dr. Munir and Niswan to present the token of justice to their Director Sir. Now again I request Professor Director Sir to present token of justice to Isma Shamima. Again, Director Sir to present the token of justice to Arshia Sultana ma'am. And lastly, I will request Professor Director Sir to present token of justice to Rajia ma'am. Next, I would like to call Professor Ismat Shamim ma'am for welcome remarks.
Good morning and a warm welcome to one and all over here. At the outset, I thank Almighty Allah subhanahu wa ta'ala for enabling us to carry out a 60th CME for teachers in Ilmul Qabalat to Amraze Niswan. This initiative is sponsored by Ministry of Ayush, Government of India. The proposal of CME was submitted in January 2022, which was approved, but the budget was not released until May 2024, nearly 2.5 years later. This is the second 60th CME for teachers, which will be organized by the department as per the modules recommended by Ministry of Ayush. And the first 60th CME for teachers was held in December 2014, almost 10 years back. So the purpose of this CME is not only to enhance the teaching skills of the teachers, but also to update the knowledge in the subject. This CME will focus on various themes such as understanding educational methodology and crafting lesson plans by eminent speaker Dr. Munir Ahmed Sir. He had delivered a very informative talk on introduction to educational methodology in his first session, which is very useful to us, and his next session is on writing lesson plans, which will be followed soon after the tea break. So today afternoon we have two sessions related to the theme Integrations of the Unani and the Modern Obstetrics to enhance the women's health outcome by Professor Arshia Sultana. On day 2, we have two sessions in the morning related to the theme Gynae Oncology, which includes mainly advancement in cervical cancer management and preventions, along with the practical demonstrations of colposcopy by Professor Dr. Sundari. She is a retired professor from Brahmanya Medical College. And in the afternoon two sessions on the same theme Gynae Oncology on integrating modern approaches with Unani medicine practices in cervical cancer by Professor Amina Nas from AMU Aligarh. On day 3, we will have morning sessions on urogynecology, which includes understanding urinary incontinence, pelvic organ prolapse in geriatrics by Dr. Vijay Kumar from Ambedkar Medical College. And in afternoon, we have sessions on exploring the Unani medicine evidence-based approach in pelvic organ prolapse by me only. On day 4, we will have 2 morning sessions on theme Advancement in AUB Evaluations and Management and Unani Medicine Approach to PRD Treatment by Professor Rafi Ahmed Chaudhary from Pune. And in afternoon sessions, we have Achieving Immunization Goals through Hands-on Training and Routine Vaccination scheduled by Dr. Fahminda Kausar from Harun Bagh. On day 5, we will be having the morning session on theme Mastering Journal Publications, Good Practices and Online Demonstration by Dr. Prakash C. from West Bengal. I think this session is very useful in writing the publications, research publications, and I request all the students to please attend these sessions. And afternoon session, the theme is Exploring the Pregnancy-Induced Hypertension from Ancient Wisdom to Modern Strategies in Prevention and Management of Pregnancy-Induced Hypertension. This will be delivered by Professor Nafis Mano from GUMC Bhopal. On day 6, we will have the morning session on theme Hands-on Training for Critical Obstetric Procedures, especially the medical and surgical management of postpartum hemorrhage. This will be delivered by Vishma Shetty from Rajashri Medical College. And in afternoon session, the theme of the session is Insight into Antepartum Fetal Surveillance and Exploring the Abortions in Rural Medicine by Dr. Sheikh Imran from Harun Bagh. So, in this CME, we have total 24 sessions, 4 sessions per day, and each session is of 90 minutes, and each resource person will cover their 2 sessions. The topics that will be addressed in this CME are of great importance, covering both the modern as well as the Unani aspect, since we deal with these issues on a daily basis in clinical practice. I express my gratitude to each and every speaker who consented to participate in this CME, and we have trainees from the different states of the country like Karnataka, Telangana, Maharashtra, Andhra Pradesh, Chennai, and so on. I warmly welcome the trainees from the different countries across the nations. I, Professor Ismail Shamim, head the Department of the Ilmul Qabalat Amraze Niswan, and the event organizing secretary would like to acknowledge Professor Abdul Nasir Ansari, in-charge director, and the events organizing chairperson for his support in providing us the opportunity to conduct this CME for teachers in Ilmul Qabalat Amraze Niswan. As you are well aware, the Department of Ilmul Qabalat Amraze Niswan is one of the founder department of IIM. Established in 2004, we have been engaged to achieve the highest standard in patient care and research ever since. Today, our department has approved 91 research scholars, majority of the whom are employed in reputed positions here to the patient care, research and teaching across the nation. A few of these alumni are the resource person of this event, while some others are attending this event as training. To keep students up to date on the subjects, the departments on the academic platform regularly conduct the symposiums, seminars, journal clubs and other events. The department is proud of more than 315 research and review papers that has been published in a variety of the international and national peer-reviewed index journals, and the faculties of the department authors more than 12 books and achieved more than 20 awards to their credit. Once again, I welcome all the trainees and hope that the 6-day CME will be successful in every aspect and that you will enjoy the Bengaluru cuisine and the pleasing climate. After completing the CME, I hope that everyone has a deeper comprehension of the subject. Thank you.
Continue with his inauguration speech from our esteemed director, Sir Professor Nasir Ansari. Sir's years of commitment towards our cause is admirable, and we are eager to learn from your valuable insights. Can we ask for a robust applause for Professor
Bismillah. Chief guest of the day, Professor Munir Ahmed Sahib, Organizing Secretary Professor Ismail Shamim and Professor Asha Sultana and Dr. Vijay Bilal. Ladies and gentlemen, dear participants, which I am seeing the faces from very first batch of NIUM, from the second batch as well. Hazarat known face from Chaga, Bulandshahr. So the crowd is quite known. They are not unknown people. Well, I'm not expert in gynecology and ops. So basically, I'm not going to speak anything specific to the subject, but I have two observations basically. One is generic and one is specific. And it's all about the clinical practice that we do, because I'm also a clinician from Lalbit. So I will talk the problems that I've seen in the physicians, in students, in consultants. The generic problem is that whenever we are treating the patient, I think we are not taking full view, the holistic view of the patient. We are not properly reaching at the diagnosis as per the temperament, as per the principles of the Unani medicine. So you know that the disease which is given in the Unani medicine, for example, is usually in the form of a symptom, and then various causes are elaborated. And then there is diagnosis as per the asbab. So we treat the symptoms only, but not as per the diagnosis, as per the asbab. So, for example, there are various disorders of tongues, for example, but there are many causes which are given in the books. Now the problem is that we do not really recognize the patient as per their causes, and we do not reach the diagnosis. Once we reach the diagnosis, then probably we will be able to treat the patient properly also. And since most of the diseases are madhi in nature, they are not ghar madhi. So without madhi or so without ghar madhi. And if it is madhi, then we understand that the treatment has to begin with musil or some other tanqiyat, tadaburi tanqiyat. But what actually I have seen in the practice, in the hospital and even in the clinics also, that the treatment most of the time is very haphazard. Treatment is not given as per the principles of the Unani medicine, because the disease is actually not recognized as per their asbab. And that's why there is hardly any effect. Sometimes there may be effect of chance, which is maybe called a tukka. To be tukka lag gaya, bahut badhiya ilaj ho gaya. But if we give the same treatment in another patient with the same symptoms, there is no effect. Why it is happening? Because probably we are not able to recognize the patient as per their asbab. So asbab may be different and the symptom may be same. So the patient has come with the same symptom, but the asbab is different in the patient. So we have to basically recognize the patient as per the asbab, and then we have to treat. So this is one of the problems which I have seen in most of the clinical practice, that the treatment is not as per the principle of the Unani medicine. So no munzij or no musil. And then tadabir, if given, they may also be haphazards. Usually it is cupping therapy which is applied. There may be the therapies of fazaja, humul, or many therapies are there which could be given, but probably they are not either in the sequence or not properly given. So, I mean, there are difficulties in their sequence also. This is a generic problem, and the specific problem, what I see is that there is a lot of patients we see in the ops and gynae OPD of the modern medicine. Why these patients are not with us? This is a problem. When we go outside, you can see people thronging outside the clinics of the MBBS, MD, gynecologists, but the same kind of patients are not there outside our OPD. Why this is happening? Why this has happened that we are not able to attract the patient? And then probably the reason lies in the efficacy that we are not going to give to all these patients. So patients do come to us, then probably we are not able to satisfy them because we are not able to recognize what is the disease and we are not giving the proper treatment. So why the patients are with them, why the patients are not with us? This is one of the problems. And if we are able to institute the proper treatment, if there is efficacy in our treatment, then the patient will come to us. So this is the high time that we have to think. The high time to think that how we have to diagnose a patient properly, and again we have to go to the basics of the Unani medicine, and we need not to look in the terms of the modern medicine. It is what we are doing, that we are recognizing we are diagnosing patients as per the modern system of medicine, and then we are giving some Hepazine treatment according to the Unani system of medicine. That's why these have an effect. So basically what we have to do is that we have to recognize an entity in Unani medicine, properly diagnose the patient as per their asbab and give the treatment as per the principle of the Unani medicine, and then evaluate the effect. And there will be a lot of patients thronging outside your OPD also. So you won't see that there are 4, 5, 6 patients sitting outside your OPD, but you will see a lot many patients are there as you find in the OPG, gynae OPDs or MBBS doctors. So that is the difference, that we are not following properly the principle of the Unani medicine. The diagnosis has been made, for example, cervical cancer, or there are many other diseases, okra or whatever. It is made as per the modern system of medicine, and the treatment is given as per the Unani system of medicine by the very absurd way. Now also urge that we have to make researches, of course, that is important. But researches have to be made as per the principle of the Unani medicine and to have the effect. Now I was just reading that I got a document on 6th May 2024 now. The government is thinking to have integrated health policy. And in the secondary and tertiary hospitals, they are going to open the clinics. And they want to have a co-location of these clinics of the Unani, Ayurveda, Siddha, Yoga, and the modern medicine. So basically they want to have integrated policy. But the matter is that it will all depend that what kind of evidences you have, how much studies you have done, whether your treatment is effective or not, there are concrete evidences available or not, whether your therapy is effective or not. Now we see that all these Ayush therapies are coming up, and they are producing a lot of effects, and they are producing concrete evidences also. So what will happen eventually, that all these people will come as an integrative Ayush clinics in other hospitals, and probably Unani may not come out. So what we have to do, we have to look at different research, and we have to produce the results as well, so that this policy, it is at the level of draft only, and nothing has been done. So it will be implemented probably in 2025. So what we have to do, we have to create the evidences and efficacy also. Evidences are not enough. We can do the research, there are evidences, but actually they do not match with the efficacy. हमने कितनी research यहाँ पे की है? We have produced a lot of evidences, but is there efficacy? In your heart, sometimes there's no efficacy, but the results are there, very profound on the paper. So if you have the result, you have the evidences, then probably you will also be invited in these co-located Unani clinics in these secondary and tertiary hospitals. So by this CME, I have gone through this brochure that you have covered almost all the important subjects here. And a lot of paper probably will be presented and evidence will be given. But I ask that whatever work we do with our sincerity, with imandari, with hard work. We have to produce the evidences and the efficacy. You said that Unani medicine surges ahead along with all other Ayush therapies, and may be a component of all other Ayush systems. And it should be well integrated with all other Ayush therapies and system with the modern system of medicine. So with these words, I say thank you.
The late Professor Munir and sir to address the gap.
To the staff, director and faculty of CME and other teachers here for their invitation. This topic of education methodology is something which is very interesting. And as Dr. Amsari was telling earlier, he was telling that there has to be a kind of alignment of the diagnosis that you make with the concept of Unani for the understanding and treatment. In fact, only when there is this alignment, anything can move forward. Otherwise, each of these factors will be pulling in different directions. You make a diagnosis which is something different, and your concept is something different, the treatment is something different. So this kind of a constructive alignment is what is really necessary. And this is exactly what we also kind of advocate in education. There has to be a constructive alignment of the purpose of education, the activity of education, and the assessment of education. And that is what we have been discussing in the previous session and the next session also. Hopefully the message will be carried to all the teachers and through you to the other faculty in your institutions and to the students. Because anything having a kind of clarity is where we can be successful. If we are working in the dark, we will be in the dark. Therefore, to create a kind of light and to enlighten and illuminate our teaching, we need to have an understanding of education methodology. Hopefully, from whichever university you come, you can influence and you can create a kind of advocacy in your universities and your institutions to have a kind of compulsory training in the basics of education methodology, so that the teaching and the assessment of the students can really improve, and the essence of Unani can be brought out more clearly within the kind of range of education methodology. Because the education methodology is a neutral tool. It doesn't belong to any system. Just like diagnostic tools are neutral. They don't belong to any system. This also is a tool which doesn't belong to any system. It all depends on how we adapt it and make it kind of internalized for our systems. Therefore, with this, hopefully all of you will be sensitized to carry this forward and not stop here. Thank you all for being here. Thank you.
Thank you, sir, for your valuable words. Lastly, I would like to call Professor Arshia Sultana ma'am for vote of thanks of this inaugural session.
Thank you, Dr. Faiza. Assalamu alaikum, all the dignitaries, on the dais, off the dais, HODs, faculty members, trainees, and PG scholars. In the name of Allah, the most gracious, the most merciful, all praise and thanks are due to Allah, the highest, for granting us opportunity to come together and inaugurate this significant event aimed at advancing knowledge in the field of Ilmul Qabalat by Amraze Niswan. On the behalf of the Department of Ilmul Qabalat by Amraze Niswan, National Institute of Unani Medicine, Bengaluru, I extend my heartfelt gratitude to each and every one of you for gracing us with your esteemed present at the inauguration of the 6-day CME for teachers in Amraze Niswan for Ilmul Qabalat. First and foremost, I express my sincere appreciation to the Ministry of Ayush for the generous sponsorship of this CME, which has enabled us to gather here and embark on this journey of knowledge. On the behalf of organizing committee, I would like to extend our heartfelt gratitude to our esteemed chief guest, Professor Munir Ahmed sir, for gracing us with their presence and sharing the invaluable insights which have truly enriched today's event. I would like to acknowledge and thank Professor Abdul Nasir Ansari sir, the organizing chairperson and in-charge director, whose vision and encouragement have inspired us all to strive for excellence in all our endeavors. A special word of gratitude goes to dedicated organizing committee of our department for their flawless execution, efforts, meticulous planning to ensure a seamless experience for trainees and speakers throughout the 6-day CME. I also extend my heartfelt gratitude to our PG scholars for their wholehearted dedication and support to make this event a sounding success. I am also thankful to all the trainees who have travelled from various parts of India to attend this program. Their active involvement and enthusiastic participation over the 6 days will undoubtedly enrich their knowledge and contribute to the exchange of valuable ideas and knowledge. Lastly, I would like to acknowledge the invaluable contribution from IT department, maintenance department, and the office staff for the invaluable support in providing us with necessary facilities and resources to host this CME. In conclusion, let us take this moment as well as knowledge that will be gained from this CME to further enhance women's health outcome and educate future generations. Together, let us continue to learn, grow, and excel in our endeavors and teach our students the best. Thank you once again. Best wishes.
Punjab Sindh Gujarat
the three components of curriculum or education. And in that we discussed about one aspect, which is planning tools of Bloom's taxonomy and Gilbert's levels. The other two will be covered in a concise manner in this session, on the teaching learning methods and the assessment methods. By the end of this session, you should be able to describe the common instructional settings, classify the teaching learning methods, and list the teaching learning media. Before we go further, let me clarify two words here: teaching learning method and teaching learning medium. This clarity is very important. Teaching learning method. Method is what the teacher does or what the teacher makes the students to do. It could be a lecture teacher is doing. It could be a self-learning activity which the student is doing under the guidance of the teacher. So whatever the teacher does or the student does is a method. Demonstration is a method. Group discussion is a method. Seminar is a method. Because these are what are being done. Medium is what the teacher uses. What the teacher uses or what the students use. This is medium. The medium could be this projector. Medium could be the board. Medium could be the chart. Medium could be the model. Medium could be an instrument. Whatever the teacher or the student are using is medium. Whatever the teacher or the student are doing is method. With that clarity, let us go further. How do we select what is the right teaching method? It cannot be an opinion, like I said that I like this is the thing, I use it. So there are some parameters, some factors which suggest logically what is the teaching method. One is the student type. We already have discussed the various student types. In that we have seen the work model, visual, auditory, kinesthetic. Suppose you see that majority of our students are kinesthetic. It can happen. Though normatively 90% of the students are audiovisual, sometimes majority of the students could be kinesthetic. Or otherwise, you have seen that in the general teaching, 90% of the students are the audiovisual, but there is a chunk of maybe 7 or 8 students who are kinesthetic. Now these kinesthetic students have not learned in the classroom or in the demonstration. Now for them what is appropriate teaching method? For them to learn. So that is what is the student type. What is the student type? So when you are doing remedial teaching, what method would be appropriate? The next factor is the context of learning. The context of learning will decide which method could be appropriate. The context could be classroom context, it could be clinical context, it could be laboratory context, it could be community context. So depending on whether it is community or it is a classroom, you can decide which is the appropriate method. For example, if it is a community method, in the community context, giving a lecture will not be that very useful. A different method has to be used there. If it is a large class of say something like 100 students, having a group discussion may not be appropriate there. So depending on what is the context of learning, the method can be selected. The domains of learning, we already have discussed in the morning, cognitive, affective, psychomotor. So depending on the domain, the teaching method can be selected. Say for example, if you want to bring about a change of mindset in the students, like how does a student be gentle with the patient? Giving a lecture, how to be gentle, is not going to create any change in the person. So there has to be some kind of a different method, like there could be a group discussion, there could be a role play, role modeling. This could be appropriate methods. So depending on the domain, the appropriate method can be selected. Then the size of the class. Size of the class could be something like which is large, small or individual. Large group is something which is above 50. Whatever above 50 is said to be large group. Around 15 to 20, around 15 is said to be a small group, and 1 or 2 is called individual group. So depending on that, you can select what is appropriate method. Say for example, if you have one student in some PhDs or in PGs, you will have one student or maximum 2 students will be there. They giving a lecture to one student is of course not of any use. Therefore, depending on what is the size of the class, the teaching method can be used, can be selected. And finally, who is in control? Is the teacher controlled or the learner controlled activity? Depending on that, you can select what is the appropriate method. Say for example, teacher controlled activities are where the teacher is in charge. Lecture is a teacher controlled activity. Demonstration is a teacher controlled activity. In that, imagine students taking control in a lecture. What will happen? So this is a teacher controlled. A learner controlled could be something like library reference or individual practice. These are learner controlled. If you demonstrate to the student, you have demonstrated. Now the student has to do the practice. As the student is doing the practice, maybe the teacher can guide. Guiding is different from interfering. If the teacher is interfering, stop now. If the teacher doesn't give a flow for the student to perform, he is keeping on interfering. The teacher taking control is going to be havoc there. Therefore, what is the teacher control method? What is the learner control method? These have to be clarified, and on the basis you can select which is the appropriate method for it. And some of these methods are overlapping. For example, you have student type, audiovisual type of students, and these audiovisual type of students, the context generally is in the classroom, and the domain is generally in the cognitive domain, and the size of class is generally large, and the control is with the teacher. So there are all the 5 things are overlapping. Sometimes 4 will overlap, sometimes 3 will overlap. So you have to identify what is that overlapping which is there and identify what is the appropriate teaching method. So this is the basic kind of formula. Now to identify what are the different methods, I have created a matrix. In that, there are 2 variables. One is the learner autonomy. Learner autonomy means how much independence the students have. Is it a teacher control or the learner control? Depending on that, you can have the learner autonomy is more. That is, on the right side, the influence of teacher is less. The influence of learner is more. And if you go to the left, the influence of teacher is more and the learner influence is less. So this is one variable. The second variable is the size of class, the group size. As you go up, the size becomes smaller. And as you go down, the size becomes larger. So taking this into consideration, if the learner autonomy is less, teacher control is more, and the group size is comparatively large, you have lecture, symposium, team teaching, panel discussion, brainstorming. These are the methods which can be used, and all of these are appropriate for cognitive domain. All of these are for large group method, and all of these are teacher controlled. Now if the learner autonomy is still less, but the group size becomes smaller, you have demonstration and tutorial. Now if the learner autonomy becomes more, and the group size is relatively large, you have seminar, group discussion, journal club, workshop, project and role play. These are the methods. And with the learner autonomy still being high, the number of students becomes less. Here you may have 15 students, here you may have less, maybe 2, 3, 4 like that. So there you have conference, fieldwork, library reference, self-learning materials, lab-based learning and individual practice. So these are some of the basic classification of learning methods. Now if you look at this little more intently, whatever you see on the left side, these are generally for UG methods. And whatever you see on the right side, These are generally for PG methods. Now to give a little more insight into these methods, I am not getting into too much details. Some of these you are familiar, some you may not be very much familiar. Lecture you all know. But lecture is said to be something which is monotonous. Like 1 full hour the teacher is talking and there is no interaction, there is no interactiveness. Now how can you bring about interactiveness in the lecture? There are methods, there are tools which can be used to bring about interactivity. Like it is said, every 20 minutes the attention span of the learners will slide down. So you have to do something to increase that attention span, to increase the attention level. So to increase that attention level, every 15 to 20 minutes, or maybe every 10 minutes, you have to interject something different. It could be something like, there are some tools like buzz session. Buzz session is, you have completed a topic, a part of the topic. After that part of the topic, you give a pause for 1 minute and tell the students to reflect on it. They can talk loudly, they can talk if they want to talk, or if they want to discuss with one another, they can discuss. So when they are doing that, deliberately included by the teacher, for about a minute, the sound that you get is something like a buzzing sound. So it is called buzz session. There could be something like a quiz that you introduce in between. Like every 10 minutes or 15 minutes. On the screen, suppose you are using a projector, you can pose a question, multiple choice question, or true or false question, and ask the students to give the answer. When the students give the answer, see, there is a low-tech method of identifying the answers. Like there are 4 answers. For each of the answer, you decide this is a color code. For answer A could be red, B could be blue, C could be green, D could be black, whatever. And the students have the same color placards with them. So you ask them, what is the correct answer? So what is the number of colors that you see? If suppose A is the right answer, you have to get red placard. If large number of students are showing different color, that means they have not understood. So this way also you can have an interaction. So this is a kind of quiz that you interject. Like that, there are many methods which can be used to make the lecture interactive. And another way of making the lecture interactive is to use one of the medium. Whichever medium, we'll come to that a little later. The symposium is a group teaching activity by the students. What you do is, there are some topics where you feel the students have to be inclusive. For example, there could be a kind of integration of learning from 1 or 2 departments. The department A, department B, there are common objectives, and these objectives can be taught or learned in a better manner when the students are involved. Or one more factor is, for a subject, any subject, the syllabus is 100 hours. But in 100 hours, it may not be possible to cover the entire theory of that subject. So for that, what is done is, there is a student hour also, a student contribution. So the student contribution could be in the form of symposium. What it does is, the students, 5, 6, 7 students you select, give them a subtopic, one component of that. The students will come prepared for it, and they will make the presentation in a series. So by that, what happens is, when the students are involved in that, they learn better. Like that, you can rotate. Now 7 students, again next time about 5, 6 students, then again 5, 6 students. Like this, some integrated teaching, you can use the students for symposium. This is called symposium. The second thing that you see here is team teaching. Now symposium is student-led, team teaching is teacher-led. When there are 2 components which coming from the different departments, the teacher of department A, teacher of department B can sit together, they can plan a common lesson plan and then make the presentation together. So that is called team teaching. And one more way that team teaching can be used is when there is some kind of a complex or complicated matter which the students cannot understand just by explanation, unless there is interaction. question answer session. And the students are not in a position to ask questions to clarify them. So there what happens, one of the teachers of that subject or expert sits among the students and he or she will raise the questions. So that there is an interaction between the teacher who is embedded there and the student and the teacher who is presenting. So with that interaction of the two teachers, some questions are raised, some doubts are raised, and that can create a curiosity among the students so that they will also start asking questions. Once they start asking questions, many things will be clarified. So this also is a team teaching. So team teaching is one more method which can be used. Like for example, you have something called non-lecture hours. So in the non-lecture hours, you can use team teaching, you can use a symposium, you can use panel discussion, which you already know. And brainstorming is if you want to discuss something new, some creativity. Say for example, a new model, new method of anything, that can be brainstorming. Now come to tutorial. This is something of a controversial issue. Because most of the time, this tutorial is built into the timetable. And your inspectors who come for the inspection, they ask where is the tutorial, what you have done in the tutorial. The tutorial is not for all students. It is not a general teaching method. It is for only the group of students who are not able to learn in the mainstream. It could be because they have a different learning style, or it could be because they have a different cognitive load, so they are not able to learn that particular thing during the regular lecture hour or regular demonstration hour. So for them what to do, you prepare a different side stream and provide intensive coaching for them. That is called tutorial. Tutorial is a remedial activity, and this remedial activity is only for those students who might not have learned in the mainstream, so that they learn and come back to the mainstream. So that is tutorial. Demonstration you all know. And all these you are aware because you are from post-graduation. I don't have to discuss much about this, except for maybe two things. One is seminar. See, there is a lot of confusion about seminar. If we recall, I have seen it in many places. Seminar is like PG student is given a topic and the PG student comes prepared with PPT. He will make the presentation. After that, maybe about 5-10 minutes there is question answer. Then if the college is very generous or if the guide is very generous, they will have some tea or coffee. This is what is seminar, as I have seen in many places. Right? Now you tell me what is the difference between this seminar and lecture. Lecture teacher is giving, seminar PG is giving. Apart from that, what is the difference? Now why should we call it seminar? Why don't we call it PG lecture? Seminar is different. See, this is a popular version of seminar. Everybody is doing, I have seen in many other places also. So this is what is accepted as seminar for, I don't know for whatever reason. But if you look at seminar, it has an interesting history. It started in Germany. Because Germany was one place where most of the educational methods evolved in 17th, 18th century. Whatever we see in the mainstream, these come from, roots are in Germany, German education. And in Germany what they were doing, seminar is, it is a kind of continuous group discussion activity. If you look at the philosophy of seminar, the philosophy of seminar is said to be Socratic dialogue. In Socratic dialogue, you have question answer. Like whatever Socrates used to do in the evenings, sit together with people, he say, I will ask question, you answer, or you ask question, I will answer. So it is a question answer session. That is the philosophy, Socratic dialogue. Now in the one-way presentation of whatever we see now, where is the Socratic dialogue? Except maybe at the end if there is a question answer. So what happens in a seminar is, it is a longitudinal group discussion over a theme. You set a theme at the beginning. It could be something like epidemiology, or it could be something like diabetes, it could be something like whatever. And that has multiple dimensions to that. What the participants do is they create chunks of that, and we say that, okay, this is the first session of seminar, this is second session, third, fourth, fifth, sixth. It can run over the whole semester. So there, whoever is the teacher will set a question. Initial question. This is the you call it trigger question. Trigger question. On the trigger question, everybody studies the whole thing around the trigger question and come. The person who is presenting will make the trigger question as the anchor to make the discussion, to start the discussion. So in that discussion, he or she may pose one more question. See, this is the thing, now what next? Somebody else will answer that. Then another question will raise from there. So somebody else will answer that. So like this, there is a question answer session which happens where they make a deep study of that particular topic. And then you set another level of question for the next continuity of that. So this is what is seminar. In fact, seminar came into the mainstream education from Germany, very interesting. There was an US president, I think it was Woodrow Wilson. He studied in Germany and came to US. He was a vice chancellor of a university before he became president of US. And he was the one who introduced that, and from there it spread. And when it spreads, a lot of diversions happen, distortions happen, and it has come like this. We have adopted whichever is convenient for us, and it is continuing as a tradition. So this is what is seminar. Now coming to journal club, very important. In research methodology, even in your maybe examination, you only have a theory paper. You don't have any practical for it. Only theory is there. And the learning also happens theoretically. What is the practical for research methodology? Journal club is the practical for research methodology. Journal club is not just reading the article. Journal club is dissecting, analyzing, evaluating in depth about the whole article. Like starting with who is the author, what is their credentials, and is there any conflict of interest for that author in any other area. See, this person has done a study and that is published. Now, who has sponsored this study? What is the conflict of interest they have in sponsoring this study? Is that interest influencing the outcomes of this study? First is that. If you see any conflict of interest, stop that article, don't go ahead with it. Then about the structure. What is the content of this? What is the structure? You have a particular structure. Does this have these components in them? And what are the implications of each of these components? So when you say, okay, now this is a study, what is the method that is used? Is it appropriate for it? What is the sampling method that is used? Is it appropriate for it? What are the results? Have they done the results properly? Is the statistical method correct in this? Now when you do all these things, what you are learning is the application of research methodology in practice. So that is what is practicum for research methodology. And then of course you have the other things which you are aware. Now one thing is role play. Role play is for, it's like a skit, like a drama, where you train the students for affective domain. Now how to do a counseling? You create a skit, create a script, and the students will enact it. As they are enacting, the others are observing, they are learning. When they are enacting, they are learning. And you can rotate all these things. So these are the methods which can be used for specific contexts. Now as I said, attention span is said to be about 20 minutes, and beyond that what happens, the attention drops. We will have to do something which is provocative for keeping the attention more. So this is what is called the Pomodoro technique. For what this is, every 20 minutes, in the whole thing you study for 20 minutes, give a 5-minute break, again do 20 minutes, again 5-minute break. So this is a method which is used. With that, you can keep on increasing the attention span, doing some activity. And this doing some activity could be something which is intervening, or the best thing is said to be a teaching learning medium. Some teaching learning medium. And teaching learning medium is said to be, they say medium is the message. The way you use or exploit medium, it carries the message. You all know the social media, how it is, and how the messages get carried with the social media, the influence of it. So this was identified by this person in the early 1940s. Here, we have the teaching teaching learning media classified as either projected medium or non-projected medium. For projected medium, you require a projection. Like this is a projection. Non-projected, we don't need any projection. The examples of this could be something like you have, this is now in the museum piece, this also is a museum piece, this also is a museum piece. This is OHP, this is slide projector, and this is called something which I don't remember. And these are the film strips and television which are on the verge of getting outdated now. Then you have the projector, interactive whiteboard, and the smartboard. Then of course you have your laptop, smartphone, and the iPads. These are all require projection. And these are appropriate when you have a large group. When you have a large group, making a projection would be more appropriate. Then, for the non-projected, you have something like a board. Then you have the chart. Then you have the flip chart. You have the handout. Or you can have the charts. And this is what you have mostly in the community medicine diorama, where you have the model of a village, model of a well. So diorama also is there. And then of course you have the models or instruments. All these don't require projection. And whatever you see here, these are the appropriate for large group. When you are having a lecture, you can use this. When you are having a demonstration, you can use this. If you are having a group discussion or you have seminar, you can use any of this. In fact, you can use these also for large group, but you need to have one for each student. Suppose you are teaching in anatomy and about osteology of a particular bone. If every student has a bone, that can be for large group also. So depending on how you make the context. And a new thing that is emerging is called podcast. Like YouTube, only the audio part of it. Even that can be used as a medium for a large section. So these are some of the media which can be used. Okay, now please read it. Clear? KZ. Okay. What happened? Why did it become clear? Okay. You can see here, this is the student, this is the teacher. And their views are not coming together. So there is no alignment. There you can see the teacher, student, both are on the same convergence. So there is a clarity. And this is what happens in our teaching. If the student is thinking something, the teacher is thinking something, they are not clear what is the thing. When the objectives are clear, when the objectives are written, specific outcomes are written, both the teacher and the student, they come together. In fact, this can be the examination also, when the student and the paper setter, when the student and the evaluator are on the same page. So therefore, writing the objectives is very, very important. This is the foundation for any lesson plan. That is the activity that you will be doing a little later, maybe after 15 minutes. You will try. I am not saying that you will complete, but you will try that. And this is the model of lesson plan. In this model, what we do is we have the lesson planning document. What is the domain? It could be knowledge, skill, a single combination, whatever can be there. And this is a metadata, which is the class, students, topic, date, time. And what is the competency? You write the competency, whatever is the competency, you can write from your syllabus. And then what are the further objectives which are drawn as a result of that competency? It could be 3, 4, 5, whatever. Then what is set induction? Set induction is something which is really important. What it means is, you don't just go there and mark with that topic. You create some kind of a curiosity. You create a curiosity and for the student to identify and relate what could be the topic. I'm not saying that in every class you have to do a kind of dramatization, but wherever possible, show some image and ask the students to identify what it is, what is its relevance, or link it with the previous whatever they have learned. And that can create a curiosity for the students to go further into the current thing. That is called as set induction. inducing the students into kind of thing. So after that you have the SLO number, you can write the SLO number there. What is the content for it? What is the appropriate material for it? Then what is the teaching learning method and media, which is the teacher activity. Like method could be lecture, it could be lecture with OH, with the projection, lecture with model, whatever it is, depending on the domain and depending on the level of the domain. Then what is the learner activity? Because learner activity is also there. So when you say the demonstration have the learner activity of observation. The next level, it is like independent practice. In the independent practice, the student, you have demonstrated, the student are doing the independent practice there. So what is that you expect the student to do? Or there could be some follow-up activity, like you have given an assignment, or there is a quiz, or there is a what you call bus session, or there could be a think pair share. All these could be the learner activity, because learners are learning now. You are including the learners. And apart from that, learner activity is not only in the classroom, it can be outside also. Because your students are not 10 to 5 students, they are 24-hour students. And you cannot cover the entire syllabus yourself. The students have to take the responsibility of completing the syllabus for themselves. So what is the learner activity you will assign there? This is called as learner activity. Then how do you make the assessment? What is the formative assessment of it? What is the summative assessment of it? And how much time do you give for each of this content? Generally 5 to 8 minutes is the optimum time for any fellow. Not more than that. Maximum 8 minutes. If it goes beyond 8 minutes, then there are 2 or 3 SLOs in that. You have to see and reorganize it. And finally, what is the follow-up activity? Then give references. Generally we give in APS style, because in education APS style is more appropriate. It is more popular. In the scientific writing it is Vancouver style, but here it is APS style. So this is what is the lesson planning document, which madam will be distributing to you after this. You will write one lesson of your choice, whatever the time you want, whatever the objective you want, you can try it out later. Not now, later. And there is a reading material also about lesson plan, that also will be, it's about 7 pages, you can read that more in depth. Now these were the objectives I had for this session. Common instruction settings, teaching learning methods and teaching learning media. Now the last component of it is about student assessment. Very briefly, the basics of student assessment. At the end of this, you will be stating what is the purpose of assessment, classify the assessment methods, and list the tools of assessment. A very brief sensitization. The purpose of assessment, generally what we know, is to declare pass or fail in the exam. The students say, we say pass or fail. That is one purpose. And for that, appropriate assessment tool has to be there. You cannot use something like some tool and say that student has passed or failed. The second purpose is to test the existing knowledge. Now what is done is there is something called as a pre-test. Generally before starting this session, we will have a pre-test, and after that we have a post-test, and the scores are compared to check how much is the learning. And this pre-test is also a tool for entry behavior assessment, to check what the students or how much the students already know. So that if you get to know what the students already know or they don't know, there could be a remedial teaching before you start. Or if the students already know, you can skip that without burdening their extra time. So this is testing the knowledge, pre-test. One purpose. Another purpose could be to give feedback to the student. As you are teaching, you are also tracking and monitoring how the students are performing. So that to improve their performance, you can give feedback. This feedback is given both for the teacher and for the student. The students get the feedback how they are doing so that they can improve. The teachers get feedback to know how they are performing so that their teaching also can improve. And as a result of this feedback, you get to diagnose what are the learning problems. Where the problem is. Is the problem with the teacher, with the student, with the environment, with the cognitive load? Which is the area where the problem is? And then you can modify the teaching learning method, you can modify the assessment method, you can modify the entire environment for remediating, to improve the learning. And then Generally what has to be done is, whenever there is a new program that is implemented, no competency based curriculum is implemented. So after the completion of the first batch of this competency based curriculum, you need to conduct a program evaluation to check how this was implemented and what were the problem areas, what were the areas that were found to be problematic, pain areas which can be improved upon. This is called program evaluation. Generally in our country there is no program evaluation. We conduct any program and then by the whims and fancies of somebody the program is totally changed. So that is how it happens, but logically speaking there has to be a program evaluation. And the last one interestingly is for safety of society. The society has to be safe because the people whom you send out are going to be responsible for the health care of a large population, and there could be a critical area where they have to take a decision, and if they are not able to take that decision, can imagine what could be the havoc. I'll give you an example. About 15 years back in the UK, there was a case in the UK court where one of the patients who had gone to their NHS, National Health Service, he said that the service was not sufficient, appropriate, it was not quality service. So he went to the court against that service. Now you may think that he went to the court against that hospital, not about the hospital. You might think he went to the court against the doctor. He didn't go against the doctor. You may think he went against that nurse. Didn't go against the nurse. In fact, the problem was with the nurse. He didn't go against the nurse. He went to court against the university which gave degree to that nurse. Right? And this thing can come here also. If there is a court case when somebody has sued the university, what the university will do? Who was the examiner? Right? So be on the guard. I am not saying that you don't pass everybody. We see, no, everywhere, everybody is passed. Practical way, nobody fails, no? And theory also we have a lot of sympathy. If they are coming closer to 30, out of 100, we drag them to 50. Kuch to kar do. Okay, you do whatever, but at least if we have the training done properly, nobody will fail. Why a person fails is because the training is not sufficient. So where we have to improve is training. And once the training improves, even the assessment will improve. So these are the purpose. Now what are the methods of assessment? We have something called as formative assessment. Formative assessment is as you are teaching, you are also making the assessment. And this is to improve their performance. And the second is called summative assessment. This is what we do in our university examinations. Generally, there is a feeling that internal assessments are formative assessment. Internal assessments are not formative assessment. They can be summative also. There is one factor which differentiates what is formative and what is summative. If you make a judgment on the performance, like the student is pass or fail, it is summative. If you make a judgment that the student is eligible to take the final exam, internal assessment, we say 50% to be eligible for final exam. You are making a judgment. If you are making a judgment, it is not formative assessment. It becomes summative assessment. We may call it formative, but it is summative. Formative is where you give feedback for improving. There is no judgment. You don't say you are pass, you are fail. You don't say you can go to the next level or not. End of the posting, you don't say you have completed the posting satisfactorily. If you say satisfactorily, it is a judgment. And that is not summative. Within the posting, if you say, these are the skills you have to still improve, you improve. And you give the feedback. That is formative. Just imagine one example. You are making a cup of tea. As you are making the tea, you keep the vessel, you keep the water, you keep the tea or sugar, whatever it is, and then the water keeps boiling and the tea is now forming. As it is forming, you are observing. What are you observing? You are observing the color, you are observing the smell. Then maybe you taste also in between. Right? All this is formative. And finally, when you switch off the stove and you serve the tea, that is summative. And that is when you say, okay, this tea is good, not good, too much of this, too less of this. All that is a judgment. So all these judgments are summative. As you are making the tea, till you switch off the stove, whatever making the corrections you do, all that is formative. So your internal assessment does not fit into this formative. So this is formative and summative. And there is one more approach. It is called as direct approach or indirect approach. Direct approach is where the student and performance is in front of you, like a clinical performance, laboratory performance. Indirect is where the student's performance is not, performance may be there, but student is not in front of you. Like your theory papers, where the student has done, who has written, we don't know. We say this student has written. So that is not something which is direct. It is indirect. So these are the two methods. And finally, there is a tool called as Miller's pyramid. Miller. George Miller was a surgery teacher in the 1990s in US, who said clinical assessment can be assessed at 4 levels. One is you assess whether the student knows or not. Basic. And this is like the first level of C1. This is C1. The next level is whether the student knows how. This is understanding interpretation. That the student can explain or interpret. This is C2. The next level is only if you are sure that the student knows and knows how, then you let the student to do the shows how. Shows how is when the student is performing. So this will have C1, C2, P1, P2 also. Right? And the last one is does, where you have the affective domain also, the quality also comes in. Where you can have C1, C2, C3, P1, P2, P3 and maybe A1, A2, A3. So that is the way the confluence of performance shapes in a pyramidal or triangular nature. So this is how the assessment is done. Depending on this tool, you can select what is the appropriate assessment tool. So that way for the level of knows, you can have multiple choice question, short open question, short answer question. MCQ, SAQ, whatever you have in your theory papers. The next level for knows how, it is for understanding and interpretation. There can be extended multiple choice question. There could be short SAQ, essay and WR. These can be used for the next level. The third level to decide or demonstrate, where you have a C1, C2, C3 also maybe and P1, P2 also, where using the checklist rating scale, these two I will tell you, KFI and SCT, these can be appropriate. But checklist is their list of activities, what the student has to do. So this is only the list where you say yes or no. The rating scale is within that list, what is the level of performance. Checklist is quantitative, rating scale is qualitative. On the range of 3, or the scale of 4, scale of 5, how much the student has performed. So it is an improvisation, qualitative improvisation of the checklist. So these two are interesting. It is called key feature item and this is called script concordance test. What happens is, let me come to this script concordance first. In the script concordance, you test how the student can perform in uncertainty. A case is given, there is a case, already a case is there, case sheet is there. In that some information is taken off. Complete case is not given. Incomplete case is given. Now the student is asked, what more do you want? What more information do you want to complete this case? The student may say that some clinical examination findings are missing, or the student may say some clinical presentation items are missing, or the student may say that I want these laboratory investigations to be done and this information. The student can identify that these are the missing links in this. And when the student says these are the missing links to complete the case, now you know the student knows exactly what is the completeness. When there is uncertainty, how does the student create a certainty? What are the factors the student will make to make it complete? This is called script concordance test. Right, this you would have used also. Sometimes some missing points you give and so that the students fill it. Now this key feature item is interesting. What it says is, item also means question. For question, generally there is one more word, called item. So this key feature item is where for any clinical decision, for any clinical procedure, for any clinical activity, there are some critical steps. To complete the decision, the student has to go through these particular clinical steps. These are called critical steps. The second component of this is that some of the clinical steps, generally some students make mistake. There are some clinical steps where the students generally make mistake. So these are the general mistakes which the students make in the clinical activity. So this body of knowledge will be there. These are the steps. The teachers, the professors, or the clinicians, they have identified that these are the areas where the students generally make the mistake. So what they do in the KFI is they focus only on those critical areas or the very areas where the students make mistake. They don't see the whole case. They only see those areas. They are very focused. If they have done it, that means they have done the rest of the things right. If they have missed it, that means they have missed the whole thing. And this also can be used as a teaching tool. The script concordance and the key feature items, this can, and checklist, this can be used, and of course rating scale also. This can be used as teaching tools also. These can be assessment tools also. Therefore, in the assessment there are three ways. One is called assessment of learning. Assessment of learning is the summative assessment. Assessment is over, so the teaching is over, learning is over, you assess whether the learning has happened. So assessment of learning, The second is assessment for learning. Assessment for learning is formative. This assessment is done for learning, that means for improving the learning. Assessment for learning. And there is a third dimension, like these, or these. These are called as assessment as learning. Assessment as learning. Learning and assessment are together. So these are together. And finally for the does, where you have performance. In the performance you have all the three domains, and in this you have something called as ASCII, objective structured clinical examination. Then you have the rubrics. Rubrics are improvement over the rating scale. In the rating scale you have only the levels which are said, this is the best, this is the excellent, this is something. But in the rubric, you give exactly what excellent means, you write exactly what is good, you write exactly what is poor. Those very specific indicators of performance are written. So that is what is rubric. And portfolio is like your journal. There are day-to-day activities which are maintained, which can be assessed as a kind of final activity. So these are some of the tools for assessment, very basic snapshot. And these are the objectives we had for this session. And with this, I conclude the session.
Second speaker to you all, she is none other than Professor Arshia Sultana ma'am, Department of Ilmul Qabalat from Amraze Niswan, NIM Bengaluru. Ma'am has revolutionized the field with their bold ideas and visionary leadership. Ma'am will be sharing her thoughts on role of Unani medicine and obstetric care, traditional Unani approach to antenatal care, childbirth and postpartum recovery. A warm welcome to ma'am.
A very good afternoon to all of you. I'm audible to all? Foremost, I'd like to thank Almighty Allah Ta'ala for giving this opportunity and bestowing His blessing to work in this esteemed institute, which is a door to the world, where I was able to accomplish my vision and mission. With this, I start my lecture. I also like to thank Minister of Ayush for sponsoring this program, and our organizing chairperson and organizing secretary for giving this opportunity as a resource person. In the name of Allah, the most beneficent, the most gracious and the most merciful, let us begin. So today, your second session will be on obstetrics, and morning we had a lecture on teaching methodology, but now we will start CME Ilmul Qabalat for Amraze Niswan. So, the theme of the second session was integration of Unani and modern obstetrics to enhance women's health outcome. So So first lecture or first session will be role of Unani medicine in obstetric care, traditional Unani approaches to perinatal care, childbirth and postpartum care. So before starting, I like to acknowledge my students who have helped me in making this PPT, Dr. Rahnuma, Dr. Zia, Dr. Usman and Dr. Zora. Learning gives creativity, creativity leads to thinking, thinking provides knowledge and knowledge makes you brave. So with this, let us start. First, in this lecture, first thing will be antenatal care. So we know it is also called as Padarbile Hamla. So what is the objective of this session? To understand the importance of antenatal checkup, components of quality ANC and number and timing of antenatal checkups. Here, I like to disclaim that whatever the material has been used in this PPT is from National Health Mission and from Unani books. In Unani, Introduction to Antenatal Care, Nutritional Guidance, Unani Medicine for Common Ailments During Pregnancy and Lifestyle Recommendations. So we all know that women who has 4 antenatal checkup have 3.3 times average that they will go for a institutional deliveries. So what is the goal of antenatal care? As we all know, because we are already teachers, the main goal is to reduce the maternal mortality, morbidity and fetal mortality and morbidity. And second important goal of antenatal care is to provide physical and mental health of women and children. So here our main target of antenatal care is not only the antenatal checkup but to improve the quality care of the mother as well as child. With this, what do you understand by the term antenatal or perinatal care? Prenatal care. Antenatal care is a systematic supervision. We can just see these 2 words, that is systematic supervision of a woman during pregnancy at regular intervals. So here we are saying that at least there should be minimum 4 antenatal checkups. So there is a regular interval monitoring of the mother to see that mother and fetus both are safe. So most important thing in antenatal care is maternal well-being as well as fetal well-being and progress of fetal growth. So this is the objective of antenatal care. When we say Unani system of medicine, usually there is a wrong concept in our mind that there is no literature available on obstetrics and gynecology. So usually we perceive that Unani mein kuch bhi nahi hai. We perceive like that. But when we have seen a literature, we are able to see that it is well described about antenatal care, intrapartum care, postpartum care. Not only this, fetal care also. Neonatal care is also described in the books. Second, as we all know, antenatal care is nothing but Tadabere Rami or Tadabere Hamla, where Unani medicine or Unani physician has described about nutrition, diet, regenerative therapies like hammam to promote and secure the health of the pregnant woman. Then we also see that some minor ailments during pregnancies like vomiting, poor appetite, constipation, palpitation, bleeding per vaginum are also discussed in the book with the treatment. And most important, Unani physician has said that the labor should be conducted by experienced midwife. So what is the importance of prenatal care or antenatal care? Most important thing is that to prepare the mother. Preparation of birth plan and identification of facility for delivery. So now we are seeing in past 10 to 15 years back, institutional delivery will not prompt. But we should thank to Government of India that they have taken on so many projects to carry out institutional delivery where the mother is paid to do institutional delivery. So we all know Janani Suraksha Yojana, like this Yojana has been developed so that the maternal and fetal well-being is maintained. So here providing quality care of well-being of pregnant women and the fetus. So we are seeing that when we are saying antenatal care, it is quality care. It is quality care. Early identification of maternal and fetal complication and timely referral. So here, why we want to give quality care of antenatal care is to prevent complications both to mother and fetus. And example, our institute is not a referral institute. It's a primary institute where we conduct delivery, but you should have a tie-up with referral institute. For example, if you see PSCs usually deliveries are not conducted there. They are referred to the higher centers, district level hospitals. So the tie-up should be there, and you should have a number of the facility referral so that the pregnant woman at the time of labor, at the time of complication can be referred. So next, before going in detail, we should know what is low risk pregnancies and what is high risk pregnancies. So here, being a teacher, you know, but here because we have gathered to update our knowledge, that's why a small slides I have put so that it can be updated. So what is low risk pregnancies? A female with age of 18 to 35 years, normal obstetric history, a pregnancy, a gravida till 4th, some say till 3rd gravida, some authors say 4th gravida, no history of medical or surgical disorders, and no abnormalities arising in current pregnancy. Opposite of low risk pregnancies are high risk pregnancies, like female less than 18 years. They come in teenagers. And more than 35 years, because we know after 30 years or 35 years, medical complications are more common. That's why age more than 35 is also included in high risk pregnancies. Previous obstetric complications like PIH, APH, PPH, etc. All primary gravidas are high risk pregnancies and all grand multigravidas are high risk pregnancies. History of medical complications. Any complications developing in current pregnancy is also a high risk pregnancy. For example, if the woman develops UTI or any other complication, then it will become a high risk pregnancy. Females with bad obstetric history like history of stillbirth or previous neonatal death. So, let us see how much you have learned in this few minutes. Can you list what are the high risk pregnancies?
Less than 18 years, more than
Age,
primary gravidas,
primary and multi, previous obstetric complications, medical complications, obstetrical complications that develops in this pregnancy also, and females with bad obstetric history. Okay? So what is the consequences of, just now I said you my objective that antenatal care should be quality care. So if you are giving antenatal care, but you are not giving a proper antenatal care, it is a poor antenatal care, then what will happen? It may affect fetus, it may affect mother. What is the effect of mother? Puerperal infections. Suppose you have not given a proper guidance, where to go for the referral, they do in a small setup, where there are chances of infection, it may lead to puerperal infections, bleeding, unsafe abortions. Usually we see that MTPs are more common, they may go in places where it can cause septic abortions and preeclampsia and eclampsia. So here our main target to give a quality care is to prevent all these complications. Then what are the major complications in fetus? Antepartum stillbirth, especially in diabetic mothers. Because there you will not have any cause, there will be a sudden death of the baby. Preterm birth, IUGR and congenital abnormalities. So we are seeing that though we are giving antenatal care, but if you are not properly counseling the patient or pregnant woman, it may lead to complications. Then we have completed what is the importance of antenatal care. Next we are going to see what is the component of quality antenatal care. Because I have used word quality, it consists 4 things: primary, essential, desirable and counseling. So I am seeing that counseling is also an important quality of antenatal care. It should be provided to all pregnant women. So how many components are there in quality antenatal care? 5? 4. What are there? Primary, desirable, essential. Primary and essential are important, then come desirable and then come counseling. Shall I go back? So how many components are there? 4. So you have to remember this component because this quality antenatal care is given by WHO is recommended and National Health Mission has recommended this quality antenatal care. So PEDC. Okay. So let us see what is the first component here. It is primary. So what is the primary essential point of quality antenatal care is registration. So you see in Karnataka, we have Thai card, and it is mandated for all pregnant women to make Thai card. So it is nothing but registration of a pregnant woman in the PSC centers and other centers. So registration and first checkup within first trimester is essential component, it's a primary component of antenatal care. Maximum 4 antenatal visits, at least 1 by medical officer, because usually in PSCs it can be done by nursing staffs. And most important, 2 doses of injection TT. You have to remember this point that now TT is not given. We have to give DT, tetanus and diphtheria. So I request all the teachers, if you are practicing antenatal care, to avoid TT and send the person for DT. Because DT is costly, it is not available everywhere. Better to send to PSCs where they can take DT. You have to follow the National Health Guidelines. If you give TT in place of DT, it is negligence. Because it is a national policy. So how many doses of DT has to be given? How many? 2. If suppose the pregnant woman is having child less than 3 years, only 1 booster dose is given. Suppose the woman has not taken DT in first 37 weeks, she has taken in 38 weeks. What will be the scenario in this case? If suppose the DT has not been given in early trimesters of pregnancy and the woman has taken at 38 weeks, it should be repeated in postnatal period also. So that is 2 doses at a 1 month or 6 weeks gap. So if suppose she has taken DT injection at 38 weeks, it should be repeated in postnatal period also. This is important. Criteria is important according to National Health Policy. An intake of at least 180 tablets of iron and folic acid. Okay, this iron and folic acid is a prophylactic dose of in antenatal care where woman has to take, suppose her HB is also normal. Then essential components, this was primary components which is mandate. Then like that essential components are history taking. I will not go in detail because all know. Physical examination we know, weight, height, BMI, physical examination, then local examination, abdominal palpation, and laboratory investigation only mandates hemoglobin, urine for sugar and protein. So it is essential for hemoglobin percentage. Okay, so we have completed 2 components, primary and essential. How is dose of DT given? How it is given? Is it IV or IM? It is how much dose? Quantity? 0.5 ml deep intramuscular injection. Where it should be given? It should be given on the upper arm or deltoid, not in the buttocks, as that might injure the sciatic nerve. Inform before giving the woman, inform her that she has been given the DT injection. Inform the woman that there will be slight swelling, pain or restlessness at the site of injection for day or 2. So this has to be informed because usually what will happen, you will not inform. So she will get worried, why I am having pain. It is better to inform the pregnant woman. What is the prophylactic and therapeutic dose of iron folic acid? Prophylactic is 180. It can previously we used to start at 18 to 20 weeks as per Datta, but National Health Policy says that we should start at 12 weeks itself until delivery. Therapeutic doses, if hemoglobin is less than 11 gram per cent or the woman is paler, 200 tablets of iron folic acid BD should be given. Okay? If it does not rise in spite, then refer the woman to medical officer. This is for skilled birth attendants or in Anganwadi the nursing staff are there, they are given this. Suppose after giving iron also, if the HB is not increasing, the woman should be referred to centers. So next, preterm and postterm pregnancy, usually we think that it is not defined in the books. It is well defined that what is preterm, what is postterm and what is term in Unani system of medicine. So they said term pregnancy is 10 months. Okay. Immunization advice, We are giving DT injection to all. It is universal to all pregnant women. If suppose the baby is less than 3 years, 1 dose. If it is more than 3 years or she is primary, we have to give 2 doses 1 month apart. What about the other status? Can all the vaccines can be given in pregnancy? Or there are some contraindicated. Which vaccines are contraindicated? Live vaccines are contraindicated. For example, rubella, mumps, measles, yellow fever. So we cannot give MMR during pregnancy. Vaccines that can be given, if suppose they come and ask, we can take rabies vaccine, yes. You can take hepatitis A vaccine, you can take hepatitis B vaccine, and toxoids can be given to pregnant women. So you should be clear what are the vaccines which can be given apart from DT. Third is, first we have completed primary, we have completed essential, now it's desirable. Desirable means if you want you can do, if you don't want you cannot. It is up to the doctor's will. So blood group and RH typing is desirable. VDRL, HIV, HBsAg is desirable. But usually routinely all the pregnant women are done all these things because we don't know at what time the pregnant woman will come to us. That's why it's better, though it is desirable, better to go for these investigations. And blood sugar testing. Again here blood sugar testing according to Indian scenario. Here because India is a diabetic hub, chances of gestational diabetes mellitus is increasing because there is rise in polycystic ovarian disease and there is rise in infertility and age. So we are seeing that gestational diabetes mellitus is increasing far. So what they have done, now they are going for oral challenge test in first trimester, second trimester as well as third trimester. But it is desirable, it is not mandatory. Fourth component is counseling. See, you can see there are so many points in counseling which we leave while we are doing quality antenatal care. Promotional of institutional delivery and stay for 48 hours. In Karnataka, thanks the government that usually we have institutional deliveries, and Kerala all the deliveries are performed in institute, whereas when we go to northeast or northern countries, now also home deliveries are performed, but it has decreased a lot in this past 10 years. Birth preparedness, women should be explained about what are the labor pains, how the labor pains will be, what care she has to take before delivery, all this has to be counseled. Recognizing danger signs and symptoms during pregnancy, labor and postnatal period. So whenever the women come to you, pregnant women come to you, we have to explain what are the danger signs depending upon the trimester. Suppose she is in first trimester, you have to explain about abortions, you have to explain about high fever. If she is coming in second trimester, chances of UTI will be more, chances of development of hypertension will be more. So you have to explain the sign and symptoms of that diseases, not hypertension. You have to explain what are the clinical features you will develop because of hypertension. Plan for complication management, diet, rest and family planning, care of newborn baby, initiation of breastfeeding, exclusive and complementary breastfeeding, Janani Suraksha Yojana, and emphasizing importance of antenatal and postnatal care. So here one important point what I like to highlight is, actually when we say antenatal visits, there are two models. One is focused antenatal care model according to WHO, and second is 2016 WHO ANC model. The difference is what means, previously we used to go for focused antenatal care model, which is followed in National Health Mission also, that is 4 visits. That is first visit in first trimester, second visit in second trimester, third 4 visit in last trimester. So we can see that first visit should be between 8 to 12 weeks, second 24 to 60 weeks, third visit 32 weeks, and fourth visit between 36 to 38 weeks. But according to 2000 guidelines of WHO, now visits has changed to contacts, because woman is not only visiting you, but she is contacting you for her all problems. That's why they have changed the word visit to contact. So first visit is only one, first trimester only one contact up to 12 weeks. You can see that in second trimester there are 2 contacts, that is 20 weeks and 26 weeks. Like after 6 weeks you can call if she is a low risk case, not for high risk cases. This is for low risk cases. Then third trimester there are 5 contacts, that is 30 weeks, 34 weeks, Then you can see that contact 6, 7 and 4, 8 is 15 days. It is 15 days care. So last, after 36 weeks, every 15 days you have to call the woman. How many visits are required for FNAC? It is not FNAC, it is focused antenatal care model. How many visits? 4. And according to 2016 guidelines, 8 visits. So we are saying first trimester, first visit, second trimester, 2 visits, and third trimester, 5 visits. So in this I will not go in detail. You already know what we have to do in first visit, second visit, third visit, and fourth visit. So first visit is mainly for confirmation of pregnancy and classifying the woman if she is a low risk case or high risk case. According to that, we have to call the patient for visits. Then we have to screen the woman. Then we have to explain the birth and emergency plan and advise and counsel. Like that, second, third, and fourth. Fourth visit important is presentation. We have to see that the presentation is normal or not. I think so many are sleeping.
No, madam.
No. Next, calculation of expected date of delivery. So we all know how to calculate because you all are seeing patients. But nowadays we don't have to calculate on finger because we are having apps. So I am not going to say what is the calculation, how to calculate EDD. So we are having apps. Already we are following the apps. So this also I will skip because you all know how to calculate LMP and EDD. Then next let us come to, once we have gone for antenatal care, what are the nutritional supplements or giza should be given during pregnancy? Because this already you people have read Datta, other books, you already know what is antenatal care. So I have taken all that things which are important for our session. So we all know that in pregnancy, according to Unani concept also, that in pregnancy the diet should be light, nutritious, easily digestible and rich in protein, which should be adequate to provide for the maintenance of maternal and fetal health, lactation and strength during labor. So the same thing has been said in modern also. Unani says you have to take light diet, modern also says the same thing. Then what is the second point said in Unani medicine? That meal should be frequent and small, as we know that emptying of stomach is delayed. That's why we say that we have to go for frequent and small meals. Then they say that in pregnancy, chick and kid meat is advised for diet as it contains easily digestible proteins. So, then we all know what are the dietary regimens which should be given in pregnancy, like egg, meat, fish, milk, dates, jaggery, honey, cheese, butter, ghee can be given during pregnancy. And again we know what are the fruits which can be advised to the pregnant woman to take during pregnancy, like kishmish, grapes, sweet, bihi, seb, all this can be given. Then Rajesh said that roasted barley flour is also very good in pregnancy. जिसको हम हरीरा कहते हैं अक्सर. Then what is contraindicated dietary regimes are the diets which causes miscarriage should be avoided during pregnancy, and the pregnant woman should not say to overeat or to starve. Both are not avoided during pregnancy. So we have to see that she should take frequent and small meals, not overeating, and the food should be prescribed according to her research. Suppose her mizaj is hard, you have to give barid foods. If her mizaj is barid, you have to give hard foods. Astringent food should be used with caution, like vinegar, bitter and sharp foods such as raw olives, peppers, chili, and likewise other foods should be avoided. So vinegar should be avoided during pregnancy, but shikanjabi can be given. Okay? Food that is difficult to digest or predisposed flatulence is also not advisable. It is not contraindicated, but it is said not to advise because it can cause gas. So lobia, vafila, chickpea, like that. Then immunobug and diuretics should also be avoided during pregnancies. Like they say, chickpea should not be given in early pregnancies. Bean, safflower, kulthi, sesame, fennel, sudha, methi, carrots, all this should not be given during pregnancy. Then there are some drugs which are contraindicated in pregnancy. We all know abal, absinthium, Arend, asarun, brinjasif, balsan, chirayata, jamal gutta. Marzanshos, Murmakki, Papita, Kurtum and Sanamaki. We know these drugs are Mudirehes and Musil, so it should be avoided. Then strong purgatives like air and Jamal Gutta should not be given in early pregnancies, whereas air can be given, castor oil can be given in late pregnancy or at the time of labor. Then smoking alcohol, we all know, I will not go into these details. Then next comes, what is the diet recommended in iron deficiency anemia? Because when the pregnant woman comes to you, we have to advise her what she has to take. She may ask, kya khana madam? We have to advise them. What is the diet we will advise? For high iron content, black gram, groundnuts, ragi, whole grains, milk, eggs, meat and nuts. So this can be given. It can increase the iron level. Along with that, we encourage the woman to take fruits and vegetables which are having vitamin C. So this I will not go. What are the new guidelines for vitamin D deficiency? They say that women are greater risk should be given vitamin D as a supplement. Women staying in South Asia, Africa, Caribbean and Middle Eastern family origin should be given vitamin D in pregnancy. Women who have limited exposure to sunlight, such as women who are predominantly housebound or usually remain covered when outdoors. So these women, they should be evaluated for vitamin D and vitamin D supplement should be given to them. Women who eat a diet particularly low in vitamin D, such as women who consume no oily fish, eggs, meat, vitamin D fortified margarine or breakfast cereals. Women with pre-pregnancy body mass index above 30. This is also a guideline stating that women who have more than 30 kg per meter square should be given vitamin D. They should be assessed for vitamin D. Other advices, we do work, rest and sleep. When the woman should be advised for proper sleep. Then movements, usually nowadays we are seeing that as the lifestyle change, the pregnant women are thinking they only have to rest. No, they have to go for light movements. Mild exercises are recommended, such as slow walk. Pregnant women should avoid strenuous sports, and extreme movements as running, jumping are not allowed. Then bathing. In Unani system, they say that in first trimester, usually bathing should not be given. But this bathing is not that, it is hammam. That hammam is different from this bathing. Repeated bathing should be avoided except near delivery time. Ibn Sina says hammam is strictly prohibited, especially in first and third trimester. So this hammam is medical hammam. Okay. Loose fitting dresses are recommended. So whatever I am saying you, this is said in Unani medicine. Sexual activity should be restricted, particularly in early and late pregnancy. The reason for avoiding sexual intercourse is the risk of cervical dilatation, stimulation of fetus, and miscarriage. The regimens, we saw that we have to avoid vivisection, cupping, and emetics, and purgation in the first and last trimester. If suppose the woman has developed any disease in mid-trimester, she is allowed. Psychological. Severe emotional and psychological stress during pregnancy should be avoided. Avoid intense fear, shouting aloud, loud noises, strong emotions, negative and positive feelings, anger and sadness. So this whatever other advices I am saying, it is given in Unani system of medicine. So as we know, coitus causes release of prostaglandin and semen, which may initiate pain and causes abortion, especially who have previous history of recurrent pregnancy loss in first and second trimester, cervical incompetence and irritable uterus. So studies have said that it should be avoided. Then we all know that constipation is more common during pregnancy as because of progestinic effect. There is decreased bowel movement and delayed stomach emptying. To relieve constipation, medicines like gulkhan, shikanjabin, shiripish, magza khaya shambar can be given. Usually there is a concept saying that khaya shambar cannot be given. Amaltas. It can be given. Post amaltas is contraindicated. Pulp of amaltas or magza khaya shambar is indicated. It is the best laxative during pregnancy. Strong mucilage is contraindicated. So let us see what are the minor elements of pregnancy. MSS gravidum, heartburn, loss of appetite, palpitation, bleeding per vagina, hemorrhoids, edema, pruritus vulvae, and back pain. So all these things, what is given in modern obstetrics book, that is MSS, heartburn, all this has been already described in our books. It is available in our literature also. So first, so what are the minor ailments of pregnancy? MSS, heartburn, palpitation, bleeding, hemorrhoids, pains, back pain, edema and pruritus. Then, as we all know, Rajesh said that female fetus is more liable for nausea and vomiting. They used to determine the sex. Why? Actually, it is illegal now, but it is given in book. I am just only discussing. Don't take it otherwise, because sex determination is illegal in India. Okay? Female fetuses are more liable for nausea and vomiting compared to male fetuses, because male is having hot temperament, that's why vomiting is less, whereas females are cold temperament, that's why vomiting is more common. And as we all know, nausea vomiting is more common in first trimester. So what is the important things we can advise? What are the things we can advise? We advise prednidoxin first. Then we advise Pantok. We advise, what else we advise? Ondansetron. Ondan we advise. First, suppose the woman is having MSS, if she is vomiting once or twice, usually there is no need for any treatment. Just counsel her that one or two vomiting, you don't have to take antiemetics. Antiemetics are only advised when the woman is having more than 3 to 4 episodes where there is a chances of dehydration, there you should advise. Otherwise, you can advise simple home remedies or simple things which are available in our home, like anar, like sharbati angur, or other store items like shasta or tamarindi, like imli, sulale imli de sakte, tamarindi. It is also best antiemetic, nothing but misri. Misri bataya, you can give, shasta is nothing but misri, you can give that. Then bihi, usually we don't give safarjal, bihi is also very good antiemetic. Then pudina, ilaichi, murabba adrak. So you can see that now there are many systematic reviews saying that ginger or adrak is a very good antiemetic during pregnancy. Then zaravan, tushanda made with soya. So we can see that simple home remedies can also prevent nausea and vomiting. Then what are the compound drugs which can be given during pregnancy? Shikanjamai limbui. It not only prevents MSS, it also helps to increase the appetite. Okay, and again because it is sore, it may have vitamin C also. So here murabbai limbui, shikanjamai and sada can be given. Purse oud. Suppose if the woman is not getting convinced to take anar, we can give purse tabashi, jawarish mastagi or purse oud. And sharbati fawaki or anushdaru sada can be given, jawarish anar. Simply, if you can't remember anything, you give jawarish anar and jawarish tamarindi. If you won't popularize your own medication, it is time that Unani will get closed. So it is your duty, if a pregnant woman is also coming, first try Unani medication. If she is not responding, then you can go for antiemetics. Astringent drugs like Gulnar, Kharabs, Badia and Karnab are used for local application over abdomen. It is not for oral, it is for, because Kharabs we know that it is mudir, so we should not give orally, so we can give locally on abdominal application. In treatment, citric acid astringent foods like purse oud are given especially early morning before getting out from the bed in empty stomach. So we know that antiemetics are always given before meals. Otherwise we can give the nuskhas also, like Unna, Alu Bukhara, Sipistan, Gulesur, Gule Gauzavan, 9 gram is soaked in articula or kevra at night, can be given in cases of MSS if it is not getting stopped with other medications. After Tankia, you can give Tabashin and Lajvat Maksud, 1 gram in mixed with Jawarish Fawake is given with 30 ml of Shabati Fawake. It is not possible to follow, but simple like Javarisho, Mastagi is there, Javarish Anar and Javarisho Tamanindi, Shikanjibur, it is easily available that can be prescribed to the woman. Suppose if you are not able to get single drugs, you are not able to make medication, ready-made medications can also be given. Then systematic review have said that ginger, peppermint, lemon, quince, pomegranate, chamomile and cardamom is having anti-emetic effect. The drugs just now I said was said in Unani. The same has been proven in with research studies that it is having anti-emetic effect in pregnancy. Then same other systematic review also said that ginger, mint, lemon, quince, lavender, orange are useful as anti-emetic. Then we are getting very systematic reviews on ginger stating that it is best anti-emetic during pregnancy. The next symptom is we have completed emesis gravida. Next is heartburn and acidity. We all know that usually women will have heartburn more in second trimester because of relaxation of cardiac sphincter. So we should advise small and more frequent meals. Why we are saying small and frequent meals? Because there is relaxation of cardiac sphincter. Use antacids. Avoid overeating and spicy foods because it will increase the acidity. To cope with this problem, in non-conventional medicine, specific drugs which increase the muscle tone are advised like astringent fruits like amla, halela, balela and jawarish. So jawarish is usually given for stomach. So here you can see why we are saying for jawarish. Then loss of appetite, again to improve the appetite we can give zaravan, shrab-e-rihani, tush, mastagi, kandur, piyaz, hardal. If the appetite is not improved, then arke gulab 20 ml and arke keda 70 ml with 7 gram shrab-e-rihani for 7 days may improve appetite or jawarish. So the tush 9 gram or shikanjamini lumui can be given. So what just now I said you that shikanjamini lumui is not only good for emesis, it also improves the appetite. Next, palpitation. We all know in second trimester usually women may have palpitation because of increased volume due to the involvement of stomach. Then few sips of lukewarm water with arke gulab. Simple. If suppose the woman is saying that she is having palpitation, you can just simply advise arke gulab with warm water. For inhalation of aroma, again you can give arke gulab will having aromatic smell. That will you can say how to inhale. Or arke mundi can be given. Mufara yakuti, dawal mist. Dawal mist can be given during pregnancy. It is good for feed fetuses or IUGR also. Darunach, we all know it is the best fetogard drug. Zaranbat, Khamire Marwari, Sharbata Tufa. Slow walk or mild exercises. If it's found failed that arke gozaban sada or ambari, arke badarin goya can be given. So if suppose the simple remedies like arke gulab is not working, then you have to go for arke gozaban or arke badaran goya. If suppose you are doubtful that palpitation is not because of pregnancy but because of cardiac disease, then specific consultation should be taken by the consultant. Bleeding per vagina, again if suppose the patient is having APH, like sometimes there may be threatened abortion, where she may be having spotting, in those conditions, not in active APH, but in where there are simple spotting as they are doubtful she is having threatened abortion, there these medications can be given. We can give Abzan or we can give oral Hafiz Dawai. In Abzan you can give Adas, Gulnan, Postana, Anjir, Kush, Halela. Whatever we are giving in a non-pregnant state, that same can be given in a pregnant state also. So we are saying it's very easy. Gulnan, Postana, Adas, Anjir or Halela. Boil in water and sirkan used. The remaining of these drugs can be applied locally on the pelvis also. Suppose the woman is having bleeding. In indeterminate bleeding or placenta previa or mild degree of abruptive placenta, we can use if suppose the patient is not having active bleeding. Then hemorrhoids, as we know, hemorrhoids are more common during pregnancy. So we can use Gule Pritmi, Maviz Munakha in Joshanda form with Shire Kasni and Gulkhan. So in my practice or in our institute we are not giving Clemefin. We are not giving Clemefin, we are not giving Dulfalac, we are giving Gulkhan. But when we are giving Gulkhan, usually we give low doses. It should be given in high doses. At least 25 grams of Gulkhan should be given. Then only it will act as a laxative. So I have seen a good results of Gulkhan. It is not only useful in constipation or hemorrhoids, it is also useful in palpitation also. Then backache, we can use Roganabul or hot fermentation, and we know that there is calcium deficiency. We can use Kursa Marwari, Kursa Kushta Marjan and Amire Marwari. So this can be given during pregnancy. Then edema. In edema they said that we can give tablespoon of sirka should be applied on foot or simat of karnab leaves may be beneficial. Local application of karnab juice with raspat and formulation of elva, sandal, fofil with anabasalip leaves juice are also useful in edema. Avoiding standing for long periods, elevate legs when laying or sitting, avoid tight stockings. Then pruritus vulva we can give muabe khitmi, shire anabasalip, abe kasni and murdasa. This is locally, not oral. Then varicosity, we all know, women should rest in same position, elevate legs regularly, avoid crossing legs, avoid long period of standing. Then cups, already I said you, what are the Unani medication which can be given in cups. Then syncope is also described in Unani system of medicine. Because sometimes the women have giddiness, all that thing. So oral administration of ambiana, arke gulab, arke badian and arke gozavan, 40 ml, 48 ml each is given orally. So anything you can give. Ambiana is also good in syncope. Arke gulab, arke badian and arke gozavan. And just now I said you, the wall with smoothadin, sharbat anar and jawarish amla are also helpful. Then Ude Salim can also be given during pregnancy along with Arke Gulab and Yakuti Mutadin. See, Gulkand Aftabi is also good with Arke Gulab and syncope. So we know what are the indicated drugs during pregnancy. Then compound drugs like Davalmis, Mufarre Yakuti, Khamire Gauzaban, Khamire Marwarid, Tiyaka Faru, all this Shiganjabin and all these drugs can be given during pregnancy. It is safe in pregnancy. But what is the important thing? When you are writing, you should know about that company. If you are writing from outside, be careful because there may be adulteration in these drugs. So better to take from the companies which you have trained. Second, important new points, screening for fetal anomalies, the combined test like a nickel translucency, beta human beta SCG, pregnancy associated plasma protein should be offered to screen for Down syndrome between 11 weeks and 13 weeks. So this is a new guideline saying that in first trimester how to diagnose fetal anomalies. Second trimester we know that we have to go for triple or quadruple test. Then for gestational diabetes, what are the new guidelines? If the body mass is more than 30, previous microsomic baby, previous gestational diabetes, family history of diabetes, family origin, and these are the important things to see that the mother is having gestational diabetes or not. So screening is done for these women solely for gestational diabetes. So obesity can be done in these women, not in all women. Then blood grouping. We know that women should be offered testing for blood group and Rh negative. Important point is what here? That nowadays anti-D injection is given at 28 weeks if the woman is Rh negative. Then again after delivery, again seeing the baby blood group, again she is given full dose of anti-D. Here also you have to give full dose anti-D. Normally you have to give, not in cases of APH. If a woman is Rh negative, now the guideline says that you have to give anti-D. Hepatitis B you all know. So what is the take home message for antenatal care? That Unani medicine, we are having good treatment in antenatal care. We can manage minor alignments with Unani treatment and it is fruitful. So next comes intrapart. Any doubts?
मैम मुसफ़िया थोड़ा सा कॉन्ट्रोवर्शियल है ना मैम प्रेगनेंसी में देने के लिए जब अपन अर्क में मुंडी हुए दे रहे तो
मुंडी सेफ है ना? हम लोग शरबत
क्या वो DT ले सकती है?
हाँ ले सकते हैं. Because it is not contraindicated ना. You can.
Not a
You
repeat
can see.
dose.
Till you
Not a
won't
repeat
know.
dose. Option.
Till you won't know. You have given TT, but you came to know you can give DT.
After 1 month.
हाँ आप अगर ऐसा है तो फिर 1 month के बाद भी आप और एक डोज भी दे सकते हैं क्योंकि पहले 3 डोज दिए जाते हैं.
Ma'am, shall we give T DAP is it necessary for TD only or can we give T DAP also? Because nowadays they are usually in private practices giving T DAP only.
We are from government institute.
So in
Yes,
government,
yes ma'am, but in government they are following only TT.
it's not updated yet.
It's not updated ma'am, actually it's not.
Listen, we are not updated. We are not updated.
No, ma'am, recent WHO guidelines. Yes, it contains criteria.
For the
Has changed. मैं भी सोच रही थी कि टीटी रहता लेकिन मैंने अभी ताई कार्ड खोल के देखा उसमें डीटी कर दिया हमारे कर्नाटका में जो कर्नाटका में जितने भी ताई कार्ड आ गए हैं उसमें चेंज हो गया वो डीटी हो गया एंड अबाउट तेलंगाना
Okay.
but it is national health policy when we say national health policy it is applicable in all over India.
Yes. But
so in Telangana we have not yet.
No, we are not doing.
ma'am, we are doing, ma'am. In PHs we are giving.
See, what is the problem now? CME should be conducted, it should be updated. Because we are not going anywhere for training. If we go to PSCs for training, you will get updated knowledge. What is happening? Because no one is there to
Ma'am,
update
in the
us.
PHCs we are giving DT only because I have seen recently one patient visiting today. PHC only.
And ma'am, I can answer you because she is a medical officer. She can answer.
Actually.
Why I can highlight?
When should we give the
Any time. It's better to give it mid-trial. It will be effective afterwards also. Postpartum also it will go.
How about folic acid? Ma'am, when to start folic acid?
Folic acid, again it depends on the breast. Suppose the woman is low risk, start as soon as the woman has come to hospital, to start till 12. After that, with iron always folic acid is good. Whole care includes supportive care, herbal remedies and management of complications. So we all know normal labor, there are three things, power, passage and passenger. If these three things are normal, the labor will be normal. I am not going in detail what is power, passage and passenger. When abnormal labor, when these three are abnormal, it will lead to abnormal labor. It can be dystocia, slow progress in labor, failure to progress, dysfunctional labor or CPD. So these are the progression which includes abnormal labor. Then abnormal labor is called as Usle Bilada. So Usle Bilada, it's an Arabic word, Asian Greek word, which means abnormal or difficult labor. So there are these abnormal labor indicators. I will not go in detail. Everyone knows what are the indicators. So we know what is the consequence of abnormal or mother and fetus, short term and long term. Short term, PPH, trauma, infection, difficult operative delivery. Long term is psychological effect, traumatic experience. Fetus is perinatal morbidity, mortality, consequences of traumatic delivery, low blood score, neonatal complications. So these are the consequences of abnormal labor. So what is the etiology in Unani medicine and modern medicine? You can see that in modern, passage, passenger and power, what are the causes for abnormal labor? If you just see this slide and compare this slide, you can see that the etiology of Usle Bilada, the abnormal labor, has been classified in Unani medicine. Here you are seeing passage, passenger and power. Here there are 5 causes: maternal, uteroplacental, fetal, external. That means the climate is also having effect on the labor and surrounding structures. So you are seeing that usually we think in modern it's well classified, but you can see in Unani also it is well classified. You see that uteroplacental causes are also given in Unani system of medicine. So this classification is given in Unani system of medicine. As per Unani concept, in this the etiology of Usle Bilada, there are 5: maternal, uteroplacental, fetal, external and surrounding structures. So malpresentation has been described in Unani medicine. We cannot say we don't have any concept of abnormal labor. It has been well described in Unani medicine. Then management of eudosia. Unani methods for normal management. It can be non-pharmacological, it can be pharmacological. Which problem is this, Anna?
Noise person.
See, it can be non-pharmacological and pharmacological. Non-pharmacological, diet, activities. Nowadays, abnormal is more common because of physical inactivity. So here, hot drinks, diet is recommended. Then activities like there should be no fever. If the fever is not there, women should advise for normal walking, sitting in different positions are advised at the time of labor. Usually what we do in normal labor nowadays, we restrict the woman on the bed. So they say that if the woman is not restricted on bed, she is given liberty to walk, sit, squat, it will ease the labor. Tadavi for sneezing is advised. Hot environment and hot items ease the labor, however cold leads to dystocia. So they say that in cold weather, dystocia is more common. Posture, I said you, it is important. Sitting in chair, reduce the compression of the fat on the uterus, helps in easing the expulsion of the fetus. Under pressure helps in easing the expulsion of baby. बटन माइक की बोले तो सुनाई दे रहा।
हाँ सुनाई दे रहा
मुझे डिस्टर्ब बहुत कर रहा। Making massage, enema, cyst bath can also help in easing the labor. For example, hammam में नरमी voice कम करनी। So हमाम नरमी और ढीलापन पैदा करता है विलादत के वक्त, and again massage is helpful in cases of to ease the labor. So where we have to do massage, कूल्हे कमर और सीना या बार-बार हल्की मालिश करें, गर्म पानी इस्तेमाल करें ताकि जिस्म में नरमी आ जाए. Then enema is also good to ease the labor. So here they said that सातर, बाबूना, मेथी, सोया, नाखूना वगैरह रोगन मिलाकर इस्तेमाल कर सकते हैं as a enema for eutosia. This is not for abnormal labor, it is for normal labor, for augmentation of labor. Then cyst bath with babuna, Aklilul Malik, नाखूना से और इलाज की जो शांति में cyst bath करा सकते हैं. गरम फर्जेजा मुसीलात देने के बाद गरम पानी में बिठाना भी मुफीद है. So here massage is helping in reducing the pain and augmenting the labor. So they say that in early stage and late first stage, the pain distribution is in these areas. So you can see that in late stages, the pain distribution is like this. So when we do massage on these areas, कमर कूल्हे के area में उन्होंने जो बताया, if we do their massage, it helps to reduce the pain. So it is also one of the labor analgesia. Actually, massage is one of the method for labor analgesia which augments the labor as well as ease the pain. Okay? What are the non-pharmacological methods? Hammam, cyst bath, सबसे important movements. Movements, diet. तो ये कहा गया है कि जब लेबर पेन से आते हैं तो लाइट डाइट देना चाहिए. Diet. Hot items. What else? Enema. Cyst bath. So, diet, activities, posture, bathing, massage, enema, cyst bath and hammam. So, hammams are also helpful in augmenting the labor. Then, version. Then, artificial rupture of membrane is also mentioned in our books that it helps in augmentation of labor. Okay, episiotomy is not mentioned in older books, but in newer version it is available. खटमाना 1 ग्राम आब नीम गर्म के साथ खाने से बच्चा फौरन खारिज हो जाता है. जरावंत का सुफूफ का हमूल करने से विलादत जल्दी होती है. Suppose खटमाना I didn't got what is it. If anyone knows, can say me because I have searched. I didn't got it. So I thought let me put the slide. Maybe I will get this answer from the audience. जरावंत का सुफूफ, then हामिले को बरकसरत जी मतलाता है. Here you see दालचीनी is very useful in nausea at the time of labor. It helps in easing the labor. It is useful in postpartum or puerperal in Locke also. It is useful in postpartum period as well as expulsion of placenta. So they are saying darchini is useful in nausea at the time of labor, not in first trimester. At the time of labor, it is very good for postpartum period, interpartum period as well as for emesis at the time of labor. औरत को दूसरे गरम औरत को 200 ग्राम आबे मेथी दे, मतलब 200 grams of आबे मेथी, मेथी वाटर, मेथी का पानी देते हैं घरों में लोग। मेथी अर्ली प्रेगनेंसी में नहीं दी जाती है, लेकिन लेट प्रेगनेंसी में इट इज द लेबर। सी अभी डॉक्टर शाहजहां ने पूछा था मैडम, ट्राइमेस्टर के हिसाब से फंक्शन चेंज हो जाता है मेडिसिन का। ओके, सो कैन यू रिमेम्बर द ड्रग्स? आबे मेथी है माँ, 5 grams, 200 ml, 200 ml और ग्राम शायद ऐसे लेते, या हो सकता है हम टाइपिंग में गलती करे होंगे, ये हो सकता है 200 ml ही होगा वो। What are the drugs? Hormone, what can we give? Zaravan. We can give Shehm Anzal also, Sudab also. They are also very good for intrapartum. So what is the drug? Zaravan. Dash is useful in nausea to ease labor, cleansing, mark and expulsion of Darjeeling. And dash 200 ml is useful to ease labor. Ave. There are many drugs. What I have said only in that only I am asking you the questions. So let us see next. Pichkari is also useful in cases of to augment the labor. It is not for abnormal labor. It is for normal labor I am saying. विलादत में मुश्किल हो तो आबे सद्दाब या जोशांते अफसरतीन या रोगन एरन हस्बे जरूरत पिचकारी में भर कर ली। तो यहाँ पर if there is atonia, uterus atonicity or like uterine inertia is there, this is useful. This is not for normal labor, it is for abnormal labor where there is uterine inertia. Okay? तो आप इस सुद्धाब जो शांति अफसरतीन या रोगन एरन हस्बे जरूरत पिचकारी में भर ले और इसके नलकी के जरिए फम में रहम में दाखिल करें. Nowadays in primaries where they, for induction of labor they are using Foley's catheter. Can we do this? We can do. Enlist the medicine of Pichkari useful to ease labor. What was there? Abe Sudab, Joshande Aftimu and Rogane Aid. Okay? This already I said you. Ibn Sina said bathing frequently. See here at the time of labor they are saying hammam should be done. It is medical hammam. Okay? Eating fatty food and fatty sweet mixed with almond oil at the time of delivery helps in augmentation of labor. In case of constipation, daily intake of sweet almond oil is useful in pregnancy. Late labor. Okay? Last trimester, term pregnancy you can see. Evidence-based medicine, as we know, Darchini helps in toning up the uterus, thinning the cervix and favors the labor because it contains active ingredient which is having natural prostaglandin effects. So why Darchini is useful to augment the labor? Because it is having prostaglandin effect. Then herein we know it's a strong purgative. Because of its purgative effect, it increases the intestinal movements which causes irritability to the uterus and lead to labor pains. So there are studies saying that castor oil is useful for induction of labor. Then dates, this one paper, 2 papers I got on dates. They said that if dates are taken at late pregnancy, it will help in labor. The effect of late pregnancy, consumption of date fruit on labor and delivery. So it is saying that it decreases the induction to delivery time or it decreases the delivery time. Then hill teeth is also useful in labor. It stimulates the secretion of prostaglandins, causes thinning of cervix and favors labor. Then methi is having histaminic potential, that's why it is useful in labor cases. Zaravan, again it is having oxytocic effect, promotes uterine contractions and favor labor. Zeera, it is having estrogenic effect. We see in Karnataka, especially in Bangalore, usually as a home remedy they give Zeera water to augment the labor. Then compound drugs with Dawal mist is useful in Dardeza. It acts like a labor analgesia. Dawal mist Dardeza ko sukun bakhshti hai. Iska matlab it is acting as labor, just epidural. It is acting like that. एंड विलादत में सहूलत पैदा करती है। 3.5 ग्राम्स 3 घंटे के वक्फे से खिलाएं। ओके। जवारिश लोई का इस्तेमाल दर्द रहम और विलादत को आसान करते हैं। जनीन की हिफाजत के लिए जरनबाद, दारूनच एंड दवाल मिस मुफीद है। सो वी नो दैट दीज आर फीटोगार्ड ड्रग्स। There is description of destructive surgery. I am not going in detail. It is obsolete. It was obsolete, but now again it is coming back. Okay. Next, postpartum. That is third stage of complication. In our Unani books, PPH, retained placenta, has been described. Inversion of uterus is also described. We think there is no literature available of intrapartum and postpartum. It is available. Third stage of labor, अगर मशीमा गिनने में ताख़िर हो तो मखरज जनीन बुखून मशरूबात और अतूसात इस्तेमाल करें। जैसे कि खरबक के जोशांदे में आगजन करना आने से प्लासेंटा निकल जाता है ना। बाद अखराज के बोरागने गुल का हमूल करें। So only suppose there is retained placenta or retained products are there, then you can use खरबक का जोशांदा। Absorption with Joshanda of dash is useful in expulsion of placenta. Okay. मशीमा को जल्द खारिज करने की तदाबीर. Suppose you want to go for active management of third stage. So they said that अगर मशीमा गिरने में ताख़िर हो जाए तो रानों से बांध दें और मखरज मशीमा बखून मशरूबात अभी मैं बताया वही है ये। अगर मशीमा ना निकले तो औरत मुंह खोलकर खूब जोर से सांस खींचे और इसके बाद छींके तो आमल खारिज हो जाता है। What is it? What we are doing? We are causing increase in intra-abdominal pressure, thereby helping in expulsion of placenta. I do this. I do. वही छींक लाना, चाहे हेयर दो, चाहे नक चिकनी दो, चाहे काली मिर्ची दो, मकसद छींक लाना है। Then मशीमा को जल्द खारिज करने के तदाबीर manual removal of placenta is mentioned in Unani medicine. Usually they say we cannot practice obstetrics, but if we have this literature, why we can't practice? मशीमा को आहिस्ता आहिस्ता खींचे। अगर इस तदाबीर से भी खारिज ना हो तो हाथ डालकर आहिस्ता आहिस्ता सरकाएं और सख्ती हरगिज ना करें। That means you should be very soft and gentle while removing the placenta. जब कुछ हिस्सा निकल आए तो औरत के रान में बांधे, फिर रहम में पिचकारी दे ताकि सब दफा हो जाए। अगर टूट जाए तो मर में बासखियों की पिचकारी दे ताकि ये झिल्ली को गलाकर निकाल दें। So if suppose there is a retained membranes or retained placenta is there, we can leave for autolysis or we can use मर में बासखियों। I am not saying anything modern today. ये वो मॉडर्न बोले तो टाइम लंबा हो जाता है। If placenta breaks, then पिचकारी of dash is followed by dash is useful. मरे में? बासली। मवागने को। कहाँ था? पहले हो और बाद में मुद्दिरात पिलाएं, फॉलोड बाय मुदिरा, ताकि यूट्राइन कॉन्ट्रैक्शन बढ़ के प्लासेंटा अपने आप एक्सपेल हो जाए। ओके। छींक लाने की तदाबीर ऑलरेडी यू नो, लॉन्ग नक चिकनीज या मिर्च इस्तेमाल कर सकते। So what are the medicine useful for sneezing? Long nut chickeny and witches here. Dhuni can also be given in intrapartum, postpartum actually. मुर्मक्की, गेंदे, बरोजा, जवाशिर, गंधक को गाय के पीते के पानी में गोलियां बनाकर, छोटे छोटे गोलियां बनाकर, पहले जमाने में फ्यूमिगेशन, हम लोग वहाँ गए थे आनंदबड़ी, तो वहाँ पर उनका धुनी का प्रोसीजर देखे, तो वो लोग धुनी ट्रेडिशनल मेथड से करते हैं। तो उसी तरीके से इसमें बताया है कि आप इसकी गोलियां बना के वो गोलियों को नीचे रख के उसको जलाएं और फिर उसकी जो धुनी निकलती है वो धुनी औरत को देना चाहिए। उधर बलसान या बरगसेर या पोस्तेसेर या शोनीस की धुनी भी मुफीद है। देन वी कैन यूज लोकल मेडिकेशंस लाइक हुमूल, आबजन, तिला, हुमूल रोगने बेदांजी में रुई तर करके रखें। इफ यू आर नॉट गेटिंग एनीथिंग, castor oil is available, you can do humul for removal of placenta. पोस्तेरीटा पानी में पीसकर रुई में डालकर भी हुमूल किया जा सकता है। शह में अंजन, मूर, बरगसुद्दा, बेल के पत्तों में गूंदकर पेड़ी या इसके अतराफ में तिला करें, ये भी प्लासेंटा के रिमूवल में मदद करता है। आबजन और हुमूल इस तरीके से और भी मेंशन किए हुए। देन फरजदा लाइक तुरमुज, शहद, मूर, तमाम दवाओं का हम वजन फरजदा रखना एतबाज़ मशीमा के लिए मुफीद है। मतलब अगर रिटेन प्लासेंटा है तो आप मूर, शहद और तुरमुज दे सकते हैं। गुले शफ्तालू का हुमूल मुर्दा जनीन को खारिज करने में मुफीद है। जुंदे बेदस्तर, कुर्तान, शहद या नफ्त सफ़ी तमाम अद्विया का भी हुमूल एतबाज़ मशीमा में मुफीद है। सो वी आर हैविंग सो मेनी ड्रग्स व्हिच कैन बी गिवन इन एतबाज़ मशीमा। इसी तरीके से पिलाने की दवाएं भी बताएं। पिलाने में तमाम मुदीरात हैं, मिश्क तरामिसी, परशोशा, अभल, हर एक 10 माशा। अभल हायर क्वांटिटी में देना पड़ेगा आपको, यहाँ पर 10 ग्राम देना है। तुरमुज, पुदीना हर एक 7 माशे, खंडे सफ़ेद 3 तोला पानी में मिलाकर डोज देकर पिलाया जा सकता है। इसी तरीके से मेथी, कलौंजी, सौंफ, अजवाइन, ये तो आपको सब घर में मिल जाते हैं। मेथी, कलौंजी, सौंफ, अजवाइन, सिर्फ बावड़न नहीं मिलता, बाकी के सब घर में मिल जाएंगे। तुकमे गदर, तुकमे प्याज, ये तमाम दवाएं या कोई भी एक दवा, मैं जो भी दवा मैसर है वो आप यूज कर सकते हैं। नेक्स्ट, पोस्टमार्टम रिकवरी। इट इंक्लूड्स न्यूट्रिशनल सपोर्ट, हर्बल मेडिसिन, इमोशनल एंड फिजिकल वेलबींग एंड कंटिन्यूड सपोर्ट। फिर पोस्टमार्टम नफास की मुद्दत लड़कों में 20 से 25 दिन होती है, लड़कियों में 35 से 40 दिन होती है। तो दिस ऑल्सो यू हैव टू रिमेंबर, इफ इट इज बॉय द पीरियड ऑफ पर्पियम इज ओनली 20 to 25 days। अगर नफास मुद्दत से पहले बंद हो जाए तो मुज़मिन बुखार और सख्त आराम लाक होते हैं। एतबार से नफास मतलब अगर पोस्टमार्टम ब्लीडिंग कम हो रही है पेशेंट को तो आप मुदीरात में तरफ ध्यान परसेंशा मिश्क तरामिश दे सकते हैं। अगर कसरत हो रही है मतलब पीपीएच हो रहा है तो उसमें फिर आप हाफिज दवाएं जैसे कुर्से कोहरबा, नौमाशी, गुले मुफ्तुम, गुलकिले अरमने, गुलनार दे सकते हैं। ट्रीटमेंट सेम है। आप जो नॉन प्रेग्नेंट स्टेट में अगर आप हैवी ब्लीडिंग होता है जो देते हो वो यहाँ पे आप दे सकते हैं। गिले अरमने, दंगल अक्पैन, कोहरबा, सोख्ता, संग जरा सब दवा आप लेके 10 माशे छांकू छानकर इस्तेमाल करा सकते हैं। हुमूल में कुर्से कोहरबा, कुर्से गुलनार दे सकते हैं। Breastfeeding, we all know breastfeeding should start within 1 hour of the delivery. We all know that first 6 months exclusive breastfeeding, followed for first 2 years with complementary feeding. Then family planning counseling is very important in postpartum period. This is our students who have done a drill or skit for family planning, so I have put that picture only here. The causes and management of Usre Wiladat are vividly described in Unani classical texts and comparable with the conventional medicine. The current evidence validates the claim of Unani scholars. Take home message: a generation which ignores history has no past and no future. Childbirth is more admirable than conflict, more amazing than self-defense, and as courageous as either one. Heaven lies beneath the feet of your mother, so respect your mother. Okay, so we have completed first session. This time I have taken less from modern, more of Unani. खजानुल अदवा में मेंशन था कि अगर ऐसा कुछ प्रोडक्ट रह जाता है रिटेल तो फिटकरी दीजिए, और फिटकरी सर्वाइकल इनकम्पिटेंस में भी आप दे सकते हैं, दोनों में भी दे सकते हैं, क्योंकि सर्वाइकल इनकम्पिटेंस में ये आपको वर्क करती है काबिज करने। असल में मसला कैसा है ना, रिटेल प्रोडक्ट्स हम रोगन गुल में मिला के देती हूँ, रोगन गुल के साथ मिला के रखती हूँ। आई हैव गिवन, क्योंकि मैं 6 to 7 पेशेंट्स को दी हूँ, बट दे शुड बी नो एक्टिव ब्लीडिंग, क्योंकि अगर एक्टिव ब्लीडिंग है तो यू हैव टू गो फॉर डीएनसी।
अभी आपने उसकी फर्जिजा की और हमबुल की बात की थी रिटर्न प्लेसेंटा के केसेस में, तो कितने समय तक हम उसको वेट करेंगे जगह के, मतलब कितने समय के ड्यूरेशन कितना होगा कि वो मतलब
नहीं, एक चीज है
करेगा? इस पर आपको बताइए।
National Health Mission, where everything is transparent and available online to how to keep your labor room, what are the things they should be in labor room. So everything is available in online, so you can take the training material from online. These slides are prepared from material available from National Health Mission and Ministry of Health and Family Welfare, Government of India. Other pictorial slides were taken directly from the internet. The people who prepare for it today, because labor room is a place where any emergency can happen at any time. For that purpose, we have to prepare ourselves today so that we can prevent problems arising at the time of complication during pregnancy or during labor. So here my agenda is introduction of maternal mortality rate, Dakshata, Lakshya. Dakshata and Lakshya are the program of Government of India National Health Mission, where the infrastructure development of the labor room has been described, and quality care of interpartum period. National Health Mission guidelines for protocols and practices in labor room. So already we are having a guideline book which is readily available online, which can be used to maintain the labor rooms. Trends in maternal mortality. Just now I said in my previous lecture that the mortality rate has decreased in past 10 to 15 years because of National Health Mission, that is Janani Suraksha Yojana, where institutional delivery has been implemented in many places. So we can see what is maternal mortality, number of residents, maternal death by number of residents live birth into 1 lakh is maternal mortality. So when we see the timeline, we can see that in 2000, the maternal mortality was 384 per thousand for 1 lakh deliveries, which has been reduced to 97 in 2018 to 20. So it took a long span of 18 years to reduce the maternal mortality. And this maternal mortality has been reduced because of Janani Suraksha Yojana, Suman Yojana and other Yojanas. So for this initiatives, government has to spend crores of rupees to see that we are able to save 1 life of a pregnant woman. So maternal mortality of India has declined from 384 in 2000 to 97 in 2020. The average annual rate of reduction in global maternal mortality rate during 2000 to 2020 period was 2.07%. And most important, India, the maternal mortality has declined by 6.36%, which is higher than the global decline. That means the institutional delivery which has been conducted in this period was effective in reducing the maternal mortality and morbidity. So here we see that in southern India, the mortality rate is very less compared to northern India. Why? Because in southern India, institutional deliveries are more common and it is practiced more, whereas in northern India, the institutional deliveries are less. Hence, the mortality rate is more in northern India. You can see, you can see here that this is northern part of India, where the red color is showing very high mortality, whereas we can see in the lower South India, the maternal mortality is decreased. And the state Kerala is number 1 to decrease the maternal mortality. It is very less in Kerala. The Government of India has implemented following schemes to tackle the issues related to maternal death. That is Pradhan Mantri Suraksha Matravita Abhiyan, that is PMSMA, which aims to provide fixed date, free of cost, assured, comprehensive and quality antenatal care on 9th day of every month. That means government is not only saying that the maternal mortality at the time of labor is reduced, but it is trying to implement it from the preconceptional or conceptional period till postpartum period. Second, we know Janani Suraksha Karyakram aims to provide free delivery including for cesarean section, free transport, diagnostic, medicines and other consumable diet and blood. Then Surakshit Matravata Ashvashan, that is Suman, aims to provide assured, dignified, respectful and quality health care at no cost or zero tolerance for denial of services for every woman and newborn visiting the public health facility. So we see that pregnant women are given due respect and government spending money to see that they are getting the facilities. So in Victoria Vani Vilas Hospital, which is the biggest hospital, maternity hospital in Bengaluru, where this Janani Suraksha Yojana and others are available, where the delivery is done free of cost. Lakshya is quality improvement initiatives. We can see that to improve the quality of care in labor room and maternity operation theatres. So the government is spending money on the infrastructure also under the initiation under the scheme Lakshya. Lakshya is quality improvement initiatives. So labor room quality improvement. So now we are seeing that if you go to Vani Vilas, it will be like a private hospital only. All the facilities are available at the time of labor. If you see the labor room, it is well equipped in Vani Vilas Hospital because of these yojanas. The Government of India has implemented following schemes. So we have seen Suman, Janani Suraksha Yojana and others. Then monthly village health, sanitation and nutrition day is also done in Anganwadis. Outreach rural camps are done to decrease the maternal child mortality, and tracking system of high-risk pregnancy is also implemented in rural areas. Health and wellness centers by organizing camps for pregnant and newborn babies. And then we have MCP card, that is Thai card, what I said you, and Save Motherhood booklet, where all the planning is given to the pregnant woman from conception till breastfeeding. So Government of India in 2015 also started one more program called as Dakshata, a strategic intervention to improve quality of care during and around the childbirth. That is antenatal and postpartum and intrapartum period. So this government initiative in 2015, that is Dakshata, helped to improve the maternal, to decrease the maternal mortality, where this was implemented in all government hospitals. So Dakshata program impact was, there was decrease in maternal mortality rate, there was decrease in stillbirth rate, there was increased 11% reduction in facility-based stillbirths and early newborn deaths, that is preterm deaths, and it provided interventions were available to adhere to all key evidence-based practices during 75% delivery in Rajasthan, 70% deliveries in Andhra Pradesh. So it was a successful program conducted by Government of India. So next, after Dakshata, which was launched in 2015, in 2017 they started Lakshya, which was to improve the infrastructure of the labor rooms. So improving interpartum and immediate postpartum care in the labor room, where the maximum maternal death and stillbirth occurs. So this was also a government initiative program to increase the infrastructure. So Lakshya program was to improve the quality of care in labor room and maternity operation theatres, to reduce preventable maternal and newborn mortality, morbidity and stillbirths, benefit every pregnant woman and newborn delivering in public health institutes, and till date 24-27 public health facilities across country has been identified. So according to Dakshata, there are some do's and don'ts in the labor rooms are expected to support improved outcome for maternal and newborn health. So here, what are the do's? Providing privacy to the pregnant woman during the interpartum period by way of separate labor room or at least private cubicles, or you can go for curtains. So it is important to maintain the privacy of the pregnant woman. Presence of birth companion during the labor, husband or a close relative can be allowed in labor room. This is also a program of Government of India only. Freedom to choose to comfortable position during birthing, that is squatting, standing, etc. So Unani system said that to ease the labor, the patient can change the position. Adherence to clinical protocols for management of labor. Don'ts: induction and augmentation of labor without sound clinical indications. That means let the patient progress spontaneously. Any verbal or physical abuse of the pregnant woman should be avoided in labor room. Insisting on conventional lithotomy position for the delivery should be avoided. Don't insist for patient to lithotomy position. Immediate clamping and cutting the umbilical cord. Don't immediately clamp. Again, there is a controversies here. Some say that do immediate, some say that do milking, wait till the pulsation are stopped, then you cut the umbilical cord. Separating baby from the mother for routine care procedure. So it should not be done. Don't do separating the baby from the mother for routine care procedure. Use of labor bed instead of table. Place baby on mother's abdomen. Do place the baby on mother's abdomen. Initiation of breastfeeding within 1 hour of birth. Don'ts. Out-of-pocket expenditures on drugs, diagnostic including demand by the staff, payment by families for celebration of baby birth should be not done. Okay? So this is also government guideline that no bribe should be given to the skilled birth attendants. Let us test what you have learned. Indian MMR declined by dash, by which is 3 times higher than the rate of global decline. It is 6.36. Dakshata strategic intervention to improve quality of care during and around childbirth was launched in dash years. 2015. National Health Mission updated standard guidelines of labor room at the delivery point in, there was one book, 2016. It was written on 2016, updated standards. So the answer is 2016. National Health Mission developed DASH initiative in 2017 for labor room quality improvement. Lakshya. Good. That means everyone are awake. Why I wanted to highlight this thing means because most of us never visit PSCs. We are not given chance to go to PSC to learn all these things because all these things are implemented in PSC. So we don't have idea. That's why I just wanted to highlight what are the important missions done in India by Government of India to reduce the maternal mortality and improve the quality care of the mother. Next, actual thing, let us start labor room settings. So what are the important things in labor room settings? The layout should, because if you see the standard guidelines, it has given how to make the infrastructure of labor room also. Suppose you are planning to open your hospital with labor room, you can follow blindly this book. Because where to keep the nursing station, where should be the labor room, where should be the toilet, everything is given in a diagram form. We don't have to work for that. So that is the plan of government. Okay. So here when we are saying labor room setting, first important thing is that layout. The layout should be like that the privacy of the woman should be maintained. Okay, first thing. Second, furniture should be comfortable. Patient should be able to sit, lie down. If she wants to stand, she can stand. If she needs a supports can be provided to her. And most important, maintenance of environment, comfortable environment. That is, temperature should be maintained in the labor room. You may, if suppose the weather is very hot, AC should be there to maintain the temperature of the rooms. Then medical equipments and supplies. If suppose your labor room is not having instruments, it will come in negligence. If you are not having facility, don't do labors. Don't do labors. If you have facility, medical supplies, medical equipment, then only go for labor. Because government has said that if you don't have facility, don't try to do labors. Then, so most important, infection control practices, because ours is an NVPH hospital. Not only that, but government in all institutes is saying that kindly practice hospital infection practices to prevent infection, because we know that till 2030 all the bugs will be resistant to bacteria and we will be soothed with microorganisms. So it is our duty to prevent hospital infection. So how you will prevent the hospital infection? Most important, hand hygiene. It prevents 70% infections by just following hand hygiene. Okay? Hand hygiene and environmental cleaning. I think so my students already know because they have attended many number of programs in NMBS training about hospital infection control practices. Then technology integration. It is mandate nowadays that all the labor rooms should have CTG machines to record the babies for fetal surveillance, to record the fetal heart rate and to see that there is any fetal distress. And nowadays, not only that, we are going for HMIS where all the records will be maintained electronic. Electronic medical recording will be also can be done in the hospital. Then emergency preparedness. For example, if some emergency is happening in the labor room, we should have all the supplies of emergency. We should be not running here and there to get the emergency things. Supportive feature, just now I said you that a companion can be sent inside by following all hospital infection practices. Not only that, because labor room is a private place, all men are not allowed, and if the workers are also allowed, the patient should be informed that male workers are coming inside. It should be followed. It is very ethical issue that the privacy should be maintained. Accessibility, for example, if the patient is handicapped, you should have wheelchair so that you can provide accessibility to the pregnant woman or delivering mother. Family-centered care and culture sensitivity. Most important, according to the patient culture or pregnant woman culture should be followed. If she wants to keep privacy, she is following parda, then you have to give her. You cannot deny that. Private and cultural sensitivity should be maintained in the labor room. If suppose she avoids male, male should not be allowed in the labor room. Then, most important, which lags in each hospital is training and education of the not only students but staff who is working in that place. For example, nursing staff, housekeeping, everyone should be trained and given education how to maintain the labor room, how to maintain the privacy, stock maintenance, everything should be trained to the labor room staff. Because labor room is an emergency place. It's not like IPD. It's always 24/7. Any emergency can happen in the labor room. Unani medicine, what it says? Sorry. That labor room should be spacious and ventilated. According to Unani concept, room temperature should be maintained, aseptic and antiseptic precautions should be taken, antiseptic dressing of both patient and doctor should be done, instruments should be clean and not to allow attendants into the labor room. So it is already mentioned in our books. Second important, we have seen the labor room setting, how to maintain the labor room. Second, we are going to see labor room practices and protocols. Most important is triaging. Second is biomedical waste. Third is disinfection. Fourth, cleaning and disinfection of the labor room. And protocol for entry of the labor room. There are how many points here? 5. More points are there. Protocol for working in the labor room. Protocol for safe care in the labor. Displays and supportive supervision for quality of care in the labor room. So, there are how many points? 5 plus 9 points. So, what are the 9 points? Triaging, biomedical waste, disinfection, cleaning and disinfection of the labor room. Disinfection means instruments, sterilization of the instruments, protocol for entry in the labor room, for working in labor room, safe care in labor, displays and supportive supervision. What I am saying is not my points, it is given in Lakshya book. What I am saying here, it has been taken from Lakshya, how to maintain the infrastructure of the labor room and what are the protocols. It has been given in National Health Mission guidelines. That is protocol and practices of labor room. From there I have taken all these points. First is triaging. We all know what is triaging. What is triaging? Priorities. For example, there is emergency. We know red means what, blue means what, black means what. Like that, in labor room also we are having triaging. Especially in institutes like small setups, triaging is very important, and in large setup also triaging is very important. There are two categories of triaging in labor room, category 1 and category 2. There are two in labor room. It is not red and blue, here it is two, category 1 and category 2. Category 1, the delivery can be conducted by skilled birth attendant. There doctor is not needed. Suppose the woman is a low risk woman with no complications, she can be managed in category 1, where nurse or skilled birth attendant can do the delivery. Whereas category 2 is a regular care is needed by the obstetrician. For example, a high risk case should be managed by the category 2. So here is the triaging which is taken from the standard book, standard protocol and practices for pregnant women. So here we can see pregnant woman obstetric history and examination is done. You are saying that the woman is a low risk, go for a normal delivery which can be conducted in category 1. If suppose she needs cesarean section, she will go to category 2. Okay. Then again, there is no risk, conduct the delivery. If there is a risk, it will go to category 2. So, how many categories are there in triaging? There are 2. First category is low risk birth, where a nurse can also perform the delivery. Okay? Second is biomedical waste management. How many people are following biomedical waste in the hospitals? And IM follows it. I don't know about the other hospitals. We are following biomedical waste. Now biomedical waste has become an act. It has to be followed by all hospitals, not only hospitals but clinics also. In Maharashtra, it has been implemented in clinics, and in Bengaluru also we are seeing that now biomedical waste has to be disposed as per the guidelines of provided by India. Okay? Shall we go in deep in biomedical waste or shall I leave it? Shall I leave or shall I say something about this? Next. So I will leave this because you all know. So we all know that biomedical waste is generated at the time of examination, immunization, investigation, diagnosis and treatment. So we know from where we are getting biomedical waste. And these waste are nothing but bandages and surgical sponge, blood products, etc. Type of waste, it can be general waste and second is biomedical waste or hazardous waste. General waste is not contaminated, whereas biomedical waste is contaminated. That's why disposing is very important. So I am not going in detail. Important thing is contaminated waste must therefore be disposed separately from non-contaminated waste. Segregation at source in color-coded waste bin as per the guideline is essential. What we see in the hospital, we don't care for our housekeeping staff. If you try to care for your housekeeping staff, you will segregate the waste where it is generated. And I request all the doctors to segregate the waste to save the housekeeping staff. Because if you put the needle in this, they may get needle stick injury and it is hazardous for the housekeeping. So it is my kind request to all the doctors that please segregate the waste where it is generated. It will be easy for the housekeeping staff to pick it up. Otherwise, they have to separate it, sit and separate, and they may get injured because of that. So I am not going in detail. You have to remember it contains 4 components: segregation, disinfection, storage and safe disposable. So I am not going what should come in yellow bin, red bin, all this you know. So I am skipping this. What are sharps? Hazardous waste is a type of biomedical waste. So, sharp is biomedical waste. Which of this is not biomedical waste? Why are biomedical waste so dangerous? They expose us to disease, they are infectious, they are gotten from hospital. They expose us to diseases. Which of these explains biomedical waste management? It prevents infection from used products. It is a way to reduce the spread of disease. It is a way to reduce amputation of legs. What is the answer? A. So you match the pen. खाली हाजरा बायोमेडिकल वेस्ट करे है ना फिर हाजरा भी पता है क्योंकि हाजरा कितने साल प्रैक्टिस किया हाजरा 5 years NABH में थे है ना फिर इसलिए हाजरा ही जवाब दे रहे हैं येलो बैग्स हाँ डॉक्टर मणिराम रेड बैग्स पंचप्रूफ ब्लैक बैग्स जनरल वेस्ट सब आंसर से हाजरा के करेक्ट रहेंगे बायोमेडिकल वेस्ट नेक्स्ट थर्ड इज डिसइंफेक्शन sterilization and processing of instruments and other supplies for labor. You see how systematically they are presented in the book. I am not saying anything from my side, it is given in the books. So in this there are two things, processing of instruments and linen and laundry. So we all know how to process the instruments and how to wash the instruments, how to soak the instruments. First is soaking, then washing. And when you are washing, how to wash the instruments also is given in the books. Instrument processing, there are 6 recommended steps for instrument processing: cleaning, inspection, packing, sterilization, storage, delivery and quality assurance. Should be good, and you should see that when we are storing the things in the labor room, it should not be stored one on the other. It should be separated. You can see how systematically it is stored here. Usually what we do, we keep one tray on the other. It should not be kept in the store like that. The room temperature should be 20 degrees Celsius. Store the device away from the direct sunlight and label them well. Most important, when we are going for sterilization or disinfection, it should be labeled. All the trays should be labeled for expiry date and other indicators. Do when cleaning the device, wear appropriate PPE, ensure detergent is prepared at the correct concentration and temperature. Keep soil instruments moist and clean as soon as possible after the procedure. Usually what happens once the delivery is over or once the serious section is over, the instrument should be, soil instrument should be clean at that time only. Not let them get dry, because once they get dry it is difficult to clean them. Take apart instruments before cleaning. Open joints instrument to ensure access to all surfaces. Use appropriately sized brushes to clean Newman device. Use soft bristle brush to clean serrations and box locks. Inspect instruments after cleaning. Follow manufacturer instruction for cleaning all medical devices. Okay? Don't use bleach to clean the instruments. Disinfectants are inactivated by organic matter anyway, so using them is waste of resources. So you should not use bleach. Using inappropriate disinfectants are also harmful. Use water over 45 degrees as it coagulates protein, making device difficult to clean. So what you have to do, don't wash in hot water more than 45 degrees. You don't have to wash. Don't use hard and abrasive items to clean the instruments. Don't scrub under running water because this produces aerosols. So what usually we do, we will open the tap and the instrument is directly washed in the tap. It should not be done for soiled instruments where their blood is. So how to make the chlorine solution? It is given, it was most useful at the time of COVID. So what are the mistakes in this? What are the mistakes? Or is it correct? There are 3 main problems in this. We should not use sodium chlorine solution to wash the instruments, please. We are having the special enzymatic detergents with which the instrument should be washed, should not be washed in the chlorine. What is the mistake here? No one is able to select, so let me see what is the answer. The use of bleach on reusable devices, bleach should not be used to clean the instruments, to wash the instruments. Soaking instruments in bleach after cleaning. So what we are doing, we have already cleaned, then what is the need to put in the bleach? So you can see in second point, soaking in chlorine solution is also wrong after cleaning the instrument. Okay? Then window is there. So what does it show? Where the instruments are stored, where the instruments are washed, there should be no window. Because the instruments will be contaminated. Okay? What are the mistakes here? One mistake? No, one more is there. Don't wash the instrument in shallow. Wash it in buckets. Don't leave shallow things to wash the instruments. What will happen? It will spill and instruments cannot be washed properly. Okay? So whole thing I have said in one thing only. One slide only. What are the basic things? The instrument should be washed with enzymatic solution which is available to remove the organic material. Then air dry it. Then packed it. After packing, it should be autoclaved. Okay? Linen, I will not go in detail because usually, but you have to remember two things in this. Clean linen and soil linen. Clean is? The linen is clean, whereas soil linen is if a person has used, or patient has used the linen, it will become soil linen. Okay? Then important points, handling of clean linen in laundry, handling of soil and used linen, transport of linen is also important. Then comes laundry. So in linen there are 4 points. Handling of clean, handling of soil linen and transport of soil linen. And then in laundry, washing procedure and processing after washing. Then handling and storage of clean linen. So this point is having only these many points. Okay? This is important for the person who are doing administrative duty in hospitals. So this is laundry cycle management for hospital linen. Cleaning and disinfection of labor. So that was instruments. Third point was instrument sterilization. This is environmental sterilization. Fumigation is not done nowadays. Okay. We are doing fogging, but now hospital infection control practices says that avoid fogging also. Go for surface cleaning. Surface cleaning is what? Nothing but mopping and cleaning all the walls and table, everything. So they are saying now go for surface cleaning, and fogging should be done if the labor room is new or new construction has been done, then you have to go for fogging. No fumigations in labor room. And please, if you are using formalin, stop using formalin for cleaning the environment. It is highly carcinogenic. So this is surface cleaning. We have to do cleaning of all the areas of the labor room. Then 3 bucket cleaning. This is 3 bucket cleaning. Means when you are mopping the floor 3 times you have to change the water. So 1, 2, 3. So in 3 there is detergent, these 2 are clean water. Okay? Protocol for entry to the labor room. Entry to the labor room should not be direct. So we should have levels of entry. Ideally a buffer zone need to be created if possible for changing of shoes, wearing of mask and cap before entering the labor room. Why we want to wear mask? Why we have to wear cap? To prevent infection. Entry to the labor room should be allowed only to the pregnant woman and her birth companion. Cleaning staff should allow periodic entry as per the SOP and protocols of cleaning. So they cannot come and go like that. There should be a protocol when a clinic person has to enter into the labor room. Before entering the labor room, slippers, cap and mask should be worn by the all visitors, including the birth companion. Any visit of people other than on-duty staff, pregnant women and birth companion to the labor room should be short in time to task. That means if suppose cleaning persons are coming, they should do only cleaning and they should leave the labor room. Entry of male staff should be restricted only to those who are on duty or have been called for any accessories or fittings. They should be polite and respectful to the dignity and privacy of the woman. So this is entry into the labor room. So as I said you, they have given how the labor room should be, where should be the toilet, everything is given in this book. Suppose if you want to go for a big hospital, how the labor room should be there, where should be the nursing station, where should be the labor room, where is the storeroom, everything is given in the layout. Here one layout I felt very good. This layout, there is a, what is this? Labor pool. That is hydrotherapy. So this can be done in an institute. Cis bath you can say. That's why I put specifically this, that cis bath can be provided in the labor room. Water bath. So this is the labor room. Ideally, the labor room should be doing like this. Protocol for working in the labor room. All staff should wear personal protective attire at the time of conducting delivery and at all other times cap and mask should be worn. Disposable sterile gloves should be used after thorough hand washing while examining and conducting the delivery. Directly you should not wear the gloves. First go for hand hygiene, then wear the gloves. Once the procedure is over, again wash your hands as per hand hygiene. Infection prevention protocols, adherence, segregation and disposable in the bin should be strictly adhered. Okay? Protocols for safe care in the labor room. We all know this. We like to move it. The pregnant woman can be made ambulatory or she can remain in comfortable position. If the woman is in active labor, the protocol or photograph should be plotted. The duty nurse and doctor should undertake thorough examination to assess the progress of labor and relevant medical and obstetric history. So you can see in this pictograph that how beautifully they have given the woman can stand, walk, side lying and squatting. So this can be done in the labor room. And I said we have to provide comfortable environment for the woman. I felt this pictograph is very good, that's why I have put it here. Positioning of labor for laboring out of different position set which can be used at the time of labor to ease the delivery. This is safe childbirth checklist given by WHO. It is very important, all labor rooms should have this safe childbirth checklist. It is before admission, at the time of labor and postpartum. So before birth, what is a safe childbirth checklist? SCC it is called as. Safe childbirth checklist. So on admission, what are the things we should see? Photograph was started not now, mother has taken antibiotic or not, she was given magnesium sulfate or not, encourage birth companion to present at birth. On admission, before birth, this checklist should be checked that we have performed our duty according to this checklist. Then just before pushing or before cesarean, what are the things should be seen according to WHO? Then soon after birth. So the safe childbirth checklist having 3 points at the time of admission, at the time of labor and post labor. For example, I will read here, is mother bleeding abnormally? Yes or no? If she is no, good. If it's yes, what should we do? So first important, call for help. Okay, then go for massaging, bimanual massaging. Consider more uterotoning. So it has given nicely. If you keep this checklist, if something is missing, you can just look it. So it can be displayed in labor rooms to follow it. Then before discharge, what are the things we should see for the patient? Pregnant woman. Display. Usually they say in labor room there should be many displays so that the healthcare workers, staffs can understand the labor room, and suppose if there is emergency, they can practice it. So, bimanual, this is active management of third stage of labor. It is mandated now by the Government of India that all the women should go for, to prevent PPH, prophylactic treatment is active management of third stage of labor. What is active management of third stage of labor?
Section of the platinum administration of dosage.
Answer is here only. Yes? There are three important points in active management of third stage of labor. Oxytocin 10 units IM. It is not giving saying IV. It is only 10 units IM. Then cord, control cord traction, and after that massage. This active management of third stage of labor is only for 10 minutes. If suppose the placenta is not delivered in 10 minutes, that means the active management of labor is not working. So you have to go for expectant or medical management of placental labor. Okay? So I am not going in detail because you people know. Then partograph, again this should be displayed, and all the cases should have partograph. Okay, it's a documentation to say that you have seen the progress of labor of a woman in intrapartum period. Then hand hygiene, I will not go in detail. One paper has been given to you. Just everyone fill and see how much you know. Because I think so many people will do many things wrong in this. Do, if it is do, put correct. If it is not done, don't, you put correct and don't. Not sure? Put not sure, leave it. It is not for exam, it is not for marks. It is just to test our knowledge. आप लोगों ने दिए ना प्री टेस्ट पेपर? फिर आप ट्रेनी है ना? डॉक्टर्स आर ऑलवेज स्टूडेंट्स है ना? नहीं आपको नहीं दिया क्या? समन? दिए थे मान को प्री टेस्ट के पेपर्स?
प्री टेस्ट वाले
ये नहीं क्या? See, no need to give, you can keep with you. अच्छा दे दो, हम वहाँ पे भेज देंगे मिनिस्ट्री में. नहीं, क्योंकि it was in module that there should be some practical slides. नहीं, posters भी है, दे दो, posters भी है, फिर देंगे आपको पेपर. अपने अपने नाम लिख दो उस पर. Hemoglobin, urine protein, and assessment of gestational age. At the time of labor, partograph, active management of third stage labor, delayed cord clamping, essential newborn care, drying and wrapping of the baby, if required, skin to skin contact of the newborn, immediate initiation of breastfeeding and injection, vitamin K, after delivery, assessment of maternal bleeding, assessment of newborn condition, and assessment of maternal condition. So these are do's in the labor room. Don'ts: no routine enema, no routine shaving, no routine augmentation of labor, no place for routine suctioning of the baby. Because as you are shocked, I was also shocked when I read this. Okay? We go for enema, we go for shaving, we go for suctioning, but as per guidelines, it is not necessary. So again, no pulling of the baby, allow natural slow delivery 3 minutes. 1 minute for head, 1 minute for shoulder, and 1 minute for body. Only assist when required at the time of delivery of the body to prevent PPH. No routine episiotomy, no fundal pressure, no immediate cord cutting, no immediate bathing of the newborn, no routine resuscitation on born. Okay? Yes. You are shocked. I was also shocked when I read this. Okay? And so you have to remember, it is not needed. Okay? Shall I move? So, posters you want to do or you understood? Leave it. Then, this is immediate management of preeclampsia case. This should be displayed in your labor. How to? Everything is available online. What you are seeing now, this was Dakshata training given by the government for 6 days. So each day they are taught everything. Okay? Then, suppose if the patient is eclamptic, how to give magnesium sulfate? That is also trained. Then newborn baby care should be like this. There should be displays of essential newborn care at the time of delivery. So this should be displayed. Then, what are the points you should see in essential newborn care? You have to maintain the temperature of the room. Okay. Then, you have to give vitamin K depending upon the baby weight. So here are the steps what should be done in essential newborn care. Then basic neonatal assistation, this should be displayed in the label. Then management of PPH, this should also be displayed, and whenever time is there you should read, and suppose you are not able to manage, you can read at that time also you can manage the case of PPH. Then uterine balloon tamponade to treat PPH. So here it is now saying that atonic PPH we know it is 80%, therefore we can prevent PPH, we can treat PPH by this. Then management of atonic PPH, again you have to keep this display in the labor room. Then postnatal care, important thing you see that correct attachment should be there. Okay? Chin touching the breast, mouth wide open, lower lip turned outward, more areola visible above than below. So more areola should be visible above than below. So this is the correct method of latching. So kangaroo mother care is given in preterm babies. So you all know what is KMC. Then this is important. According to Dakshata National Health Mission and according to guidelines, all the labor room should have 7 trays in the labor room. There should be 7 trays in the labor room. It is mandated by the government. What are the trays? Delivery tray, episiotomy tray, baby tray, medicine tray and emergency drug tray, and then MVA tray and PPICD tray. So this should be there in the labor room. I think so I have given you the printout. Especially if you are running labor room. Suppose someone is working in labor room, this emergency drug tray is mandatory. Usually what happens, patient will not go in complication. But one patient goes in complication, we see that all the doctors are running here and there to get the emergency things. Sometimes you may not get a tape also. You may not get 5 ml syringe also. So you maintain everything in emergency drug tray. I have given you the printout because I can't read out here. Then additional trays, examination tray, PPH management kit and severe preeclampsia and eclampsia management kit. I am skipping this. I wanted to do group activity to see what is in the trays, but I am skipping it. Okay. This is checklist what I have given for bimanual. Compression of the uterus and condom tamponade. I have given you the checklist. Try to follow it and try to experiment it at your home. observing the progress of labor. How many trays are to be kept in labor room as per Government of India? 7, 5, 8, 7. 2 नीचे थे MVA और PP IUCD. Antenatal corticosteroid should be given to all pregnant women. Then when it is given, if suppose the woman is having preterm, that is labor pain between 24 to 30 weeks, 34 weeks for lung maturation. What is the loading dose of injection magnesium sulfate? 14 grams. What should be done routinely to reduce perineal tears in primary gravida? Episiotomy, catheterization, adequate perineal support or enema? No. C. Adequate perineal support is the answer. Okay, regular episiotomy should be avoided in primary gravida also. So answer is adequate perineal support. Which of the following is not a sign of good attachment during breastfeeding? Chin touching the breast, mouth wide open, less areola is visible on the upper side as compared to lower side, lower lip turned outward. What is the answer here? C. Sugar attentively somewhere. Select the correct statement about the use of oxytocin during labor from following oxytocin is given. Only women having slow progress of labor, only to mothers having PPH, as an infusion with IV fluids to all women before delivery, to all mothers within 1 minute of delivery of the baby. To all mothers within 1 minute of delivery. It is active management of thirsty. Which of the following is correct about decontamination of the instruments? Immerse the used instruments in 0.5% chlorine solution. Picture में बताई थी मैं नहीं use करना है ना. Keep the instrument dipped in Savlon solution. No. Immerse the used instrument in 0.5% chlorine solution for 10 minutes. No need to decontaminate it if autoclaving is done. So what is the answer? What is the answer? Actually, this question, there is 2 things you have to remember. The answer is actually C. Suppose you are not having enzymatic disinfections. That is 0.5 for 10 minutes only. But after washing, before washing you have to soak it. Soak it. It is this, but nowadays they are saying not to use it. Okay? The answer is C. This I am not going. What are the eligibility criteria for KMC? Low birth weight babies, sick, hemodynamically stable babies need special care. What are the 2 components of kangaroo? Mother care, skin to skin contact and exclusive breastfeeding are the 2 main components of kangaroo mother care. So this is not very important for you people. Supportive supervision for quality of care in labor room. For that purpose, it is said that there should be checklist in the labor room to see that all things are followed or not. Okay, cleaning checklist should be there. Facility in charge should visit at least twice during each week. Medical officer should visit at least twice every day. Nursing supervisor should visit at least once in every shift. Then only the quality care can be maintained in labor room. With this, thank you. If you give me 15 minutes, I will discuss some case discussion which we carried out.
Were given to me to control the bleeding as well as the pain. Lekin, I was not comfortable with those medicines because I was having giddiness. Then as it subsided, after a week or 2, I randomly came here to see Arshia ma'am. Like I didn't know Arshia ma'am, but randomly I came here because before to this also I was consulting here for some leg pain, neuropathy pain. So मैं यहाँ पे आई and I met her and I was given a treatment for leech therapy. And she consulted me. I was consulting her for leech therapy, which was a new concept to me. मैंने कभी सुना नहीं था इस बारे में. So I thought, let me know फिर मैंने भी कुछ अपनी तरफ से भी उसके बारे में कुछ रिसर्च किया, पढ़ा वगैरह. तो and after we had to come for 3 to 4 sittings. In 3 to 4 sittings, totally 10 sittings were recommended to me. From fourth sittings, my bleeding came down, my pain completely came down. And I completed 10 sittings, and now alhamdulillah since 1 year I am not on any medicines. My pains are zero and my bleeding is moderate. Like first or second day it's a moderate bleeding with clear blood. Initially I was having lots of blood. जो blood clots निकल गए थे उस वजह से my blood count came, HB level came to 6. And I had to take again additional treatment for iron injections वगैरह सब लिया. So that 1.5 months or 2 months it was very crucial for me. अभी overall health भी मेरी अच्छी हो गई है. My cycles are regular, pains are normal, and latest scan is also showing that the cyst is reduced now.
आपको इस last who I have seen, she was 40 years. She was educated. She came with heavy menstrual period and severe dysmenorrhea. And the scan showed bilateral ovarian endometriotic cyst. She was really worried because she didn't wanted to take any hormonal pills. So this is her previous cycle and current cycle. The PPAC score was 1840 when she came to us. Then the investigation showed that CA125 was normal for her. But the most important thing, clinically she came with heavy menstrual periods and secondary dysmenorrhea. That was our main target first. And then we thought, let us see what is the scan showing. She said, madam, I will not go for any modern treatment. I need Ayurveda treatment. I said, we are not doing Ayurveda treatment, we are doing Unani treatment. Then I said, I have studied some cases where leech therapy was given for this condition. Are you willing to take it? First I took the consent of the patient. When the patient gave me the consent, then only I proceeded. So here this is the scan of 1st November 2023. It was showing 2.8, 2.53 centimeters endometriotic cyst. Here it can be functional cyst also. But here you can see it was not functional cyst because the patient was having secondary dysmenorrhea as well as heavy menstrual bleeding. So the chances of functional cyst was less in this case. Left ovary is adherent to the uterus, mildly thickened endometrium. Adherence is showing that the patient was having endometriosis. So these are the report of the patient. You can see at 28 February 2023, the size was 3.2. In 2022, it was less, 2.8. Usually what happens? Usually they give a gap of 3 months to see it's a functional case, functional ovarian cyst or endometriosis. So this report shows that she was having persistent cyst. Because in November she went for scan, there the cyst was present. Again when she went for February 2023, there was cyst. So we diagnosed with ovarian endometriotic cyst with secondary dysmenorrhea and heavy menstrual bleeding. So we started with Unani medication which were available in our institute, thinking that it is having progesteronic effect. One thing. Second, Ushba is useful in, it is a monolevara. That's why I gave margarine Ushba to the patients. Then in this patient we directly went for leech therapy. First, second thing, 4 sittings were done for her. She was anemic, we gave Kursa for her. Here, all the patients were not given same treatment. Every patient was given different treatment depending upon patient's symptoms and क्योंकि हम जब कलम चलाते हैं तो कलम अल्लाह ताला की तरफ से चलता है. We don't prescribe medication. Okay? तो year 23, her scan showed right ovarian hemorrhagic cyst with volume of 34 cc. Then again 11th May 2023, 19th May again this report. She went for surgery in May 4th. May 4th scanning is showing hemorrhagic cyst. On 11th May, one day before she went for, 11th May she went for surgery. In that it showed it was an endometriotic cyst. Cyst was removed. This is the surgery done in May 2023. Then after doing surgery, they again went for scan because she was not getting any relief in pain. So it again showed that the endometriotic cyst was like that only, with collection of 43 cc. Though she was operated, cystectomy was done 1 month back only. Then in November 2023, again you can see the cyst has increased in size by 5.5 into 4.2 into 5.4, and the volume is increased to 66 cc. Okay, you can see that though she was operated in May, but the size of the endometriotic, and you can see volume inside is not written because we didn't say him to what to see. Just we said that just rule out she's having endometriotic cyst or not. Okay, but the most important thing is within 3 months there is no pain, because important is patient's quality of life. There is a drastic change in her quality of life. Now she is able to perform all her work. She is able to take care of the children. And day before yesterday or 2-3 days back only she had a menstrual period. I asked, what about your pain? Madam, I don't have any pain. Here, because in endometriosis we see fibrosis, which is causing pain to the patient. When we are giving leech therapy, mostly it is helping in fibrolysis of the fibrous tissue. And maybe that is helping the patient for decrease in pain. Second, it is having anti-inflammatory, and we know that inflammatory markers are increased in endometriosis. Okay? So when the leech bite, it causes extracellular matrix degradation. Then only the leech can suck the blood, because as soon as the leech attaches, there are chances of coagulation of blood. So anticoagulants are released by the leech. It inhibits the adhesion, aggregation and coagulation, increases blood flow, protect itself and avoid reduction. So these are the functions once the leech just attach. If it doesn't suck also, it is releasing its enzyme. So we should not think that bloodletting that blood zyada is not important. Only the sucking property is more important here. Okay? So this is one patient, 27 years old, nulli gravida, married life 2 years. She was anxious to conceive. Her name is Pooja. She was a known case of polycystic ovarian disease, taking allopathic treatment since 1 year. Okay. Spelling mistakes because I didn't verify it. Okay. When she came to us, she was UPT negative. Then we went for all the investigations were already present. So I didn't went for any investigations. Directly I started the treatment. She was having polycystic with primary infertility. So here what I did, I didn't treat her polycystic. I treated Amraze. What I did, because she had irregular periods, I thought let us start with Munzil and Musil. So I gave 1 month. Actually Munzil, when you are giving, you should follow the protocol. कि नर्स में change आना चाहिए, बॉल में, but it is not possible. So, because in my experiment, what I am trying to do, I thought because अभी physical inactivity ज़्यादा है, मादा ज़्यादा जमा हो रहा है. Usually they say that 11 days, 21 days, soda should be given. But here I am giving for 40 days. Okay? And she was given Aslesus, Dachini. Then you can see she was given Musil. In this patient I have given her Musil with castor oil along with Munzij. And then after that I gave Mohavia, Palasapa, Amire Gozaban and Itriphilis Taqudus. Itriphilis Taqudus is very good drug for all Amraze case, because we know that hypothalamic pituitary ovarian axis is very important for menstruation. So we are now trying to treat the brain also here. I have not given her antibiotic because already she has taken the antibiotic. So we started with Majunushva, and you can see most of the drugs what I have given is prepared our institute, because I want to save the patients money. Okay? Habbe Suranjan, Sharbate Zanjabil, Kurse Habis. Because Habis was having, here Habis drug was having all Habis that I tried, but the patient didn't respond. Then I called Dr. Abdul Aziz from IBT department. I asked her, one case is a breast abscess. She's having discharge, lot of discharge. What shall I do? He said, give Gulab Hafiz. give Gulagrafis for 3 days. You can't imagine, within 3 days, the discharge stopped. 4th day, there was no discharge. There was no pus discharge from the abscess. So we gave Gulagrafis packing for 3 days. Continuously we called her for 3 days. We gave Gulagrafis packing. Then we changed the treatment along with oral treatment. Then what we used to do, we used to wash with betadine. We used to wash with hydrogen peroxide. Then we used to clean with Zarur-e-Zaj. When the wound was clean, then we used to pack with more Anzaru than Elva. Once the discharge decreased, after Gulagrafis, we gave more Anzaru than Elva to the patient. Okay? And patient was called alternate day, then she was not able to come. I said, no problem, whenever you are free, you come. But don't miss the follow-ups. This is the patient. Second dressing, you can see so much of swelling is there. Pure orange is there. You can see the edema. Third dressing, you can see there is no discharge. In 3 days with Gulagrafis, there was no discharge. Then slowly you can see, fourth, you can see how the forceps is going from here to there. It was complete fistula. She had 2 abscesses. They got connected. It was around 6 inch. You can see the Caesar. Okay. Then you can see within 12th to 15th dressing, it was completely healed. Okay. With the photos, I said I want to keep it more Anzaru than Elva. So this is the team who have worked for this. Dr. Fazmia, she is from Sri Lanka. She was the person who promoted my madam, do Unani treatment, we will get response. Okay. Then you can see Sumbul, Hina, Kaikasha, Arfa and Tehsin, they are seniors and juniors here. Okay. They worked hard for this patient and Alhamdulillah this patient responded with the treatment. My students from inception till now that who have helped me to work and to make this story success. And I pray for the endeavors also that they should also practice Unani. But I feel very like the people who are going in academics, for them only teaching is important, patient care is zero. I really feel very sad for that. I can't do anything, I can't help, I can pray. Because I know what are the situations of colleges, so I can't blame them. But a small step forward may bring a drastic change. Okay? Especially endometriosis, there is a scope. You can earn money. With this, I really thank all for giving your time, precious time to me, giving more. I took your 40 minutes more. क्योंकि लीज छोटे छोटे थे, उतने छोटे लीज में भी इफेक्ट आया, शायद बड़े लगाते तो और जल्दी आता.